Good morning, selamat pagi, Ibu dan Bapak sekalian. Good afternoon and good evening, depending on where you are. My name is Dia Hadistiona Luri or Ruri, and I would like to welcome you all to day 3 of the 38th Indonesia update. The topic for this session is the health outcomes in the life course. First of all, we would like to acknowledge and celebrate the first Australians on whose traditional lands we meet and pay our respect to the elders past and present. In this session, we have a great lineup of speakers. The first speaker is His Excellency Bapak Y. Kristianto S. Legowo. Selamat pagi, Pak, from Indonesia.
Selamat pagi, selamat siang untuk teman-teman di Australia.
He is the Indonesian ambassador to Australia and Vanuatu, and he will deliver the welcoming remarks. And after the welcoming remarks, we have a panel presentation from Dr. Ade Prastiani, who will be speaking about liberation for mental health. Ade is a research fellow for Together Mental Health, Center for Public Mental Health, Universitas Gadjah Mada. After Ade, we have co-presenter Dr. Salut Muhyiddin and Dr. Jericho Pardosi, who will speak about maternal health, past, present, and moving forward. Dr. Muhyiddin is a senior lecturer at Department of Management at the Macquarie University, and Dr. Pardosi is a lecturer at the School of Public Health and Social Work, Queensland University of Technology. The third presentation, also co-presenter, will be presented by Dr. Diana Contreras Suarez and Professor Lisa Cameron, who will be speaking about disability in Indonesia. Dr. Suarez is Senior Research Fellow at the Melbourne Institute of Applied Economic and Social Research at the University of Melbourne, while Professor Cameron is the Director of Disadvantage and Wellbeing in the Asia Pacific Program at the Melbourne Institute, University of Melbourne. She is also an affiliated professor of the MIT's Poverty Action Lab. Please note that there will be a combined Q&A session at the end of overall presentation. And for audience on Zoom, you can ask question in two ways. You can write question on Q&A box or clicking the raise hand icon. For those on YouTube, you can write the question in the comment box. Right. Now it's an honor for me to invite His Excellency Ambassador Kristianto Legowo to deliver the welcoming remarks. The screen is yours, Pak. Silahkan.
Terima kasih, Bu Ruri. Thank you so much once again for the kind introduction. Pak Blaine Lewis, Director of NU's Indonesia Project, Ms. Kate McClinton, Project Manager of the NU Indonesia Update, Pak Firman Witular, dan Ibu Aryan Utomo, Conveners of Indonesia Update, distinguished speakers for today's panels, esteemed participants for today's conference, teman-teman sekalian yang sangat saya hormati, good afternoon from Canberra and good morning, of course, to everyone who are in Indonesia. It is indeed once again a great honor for me to be part of the Australia National University's annual Indonesia Update. I'm especially grateful to be invited to deliver the welcoming remark for the third and final day of this year's event. It is quite unfortunate that we are unable to meet in person. Nevertheless, I'm encouraged to see that we continue to persevere and adapt amidst this global pandemic. In time of these great challenges and an unprecedented view on how we perceive life in the new normal, I believe that Indonesia Update 2021 is a very timely and relevant event. We have seen the pandemic unveil vulnerabilities, particularly in healthcare, not only in Indonesia, but also worldwide, including also in Australia. And this is the time for us to strengthen our relations. This is the time for us to strengthen our partnerships instead of placing judgment on one another. We need to offer solutions together for us to be able to overcome this challenging time. And these are efforts that we need to persist and endure in the years to come. We have already seen the gracious assistance provided by the Australian government to Indonesia as part of this solution finding effort. We have received economic support, medical supplies, and vaccination even to assist in our battle against the pandemic. And once again, on behalf of the government and the people of the Republic of Indonesia, I would like to sincerely thank the government of Australia for their continued extension of support. Despite public information and social media reports, which can be inaccurate, Indonesia is grateful that Australia continues to have confidence in us amidst this pandemic. We are close neighbors and we are good friends to one another. Echoing the word of the Minister for International Development and the Pacific Cooperation during his remark on Wednesday, partnership between our two countries will be key for us to move forward in this pandemic. Throughout this past year or so, we have seen the Australian government consistently and unfailingly engage very closely with the Indonesian government to assist us in managing this pandemic. Just last week, Minister Mary Spain and Minister Peter Dutton have been in Indonesia to meet with Minister Marsudi and Minister Prabowo. The joint statement of the 2+2 meeting have further reiterated Indonesia and Australia's commitment to deepen cooperation under our comprehensive strategic partnership and recognize our strong ongoing cooperation in response to COVID-19. Additionally, the positive trade trend between our two countries for the first half of this year further demonstrate our strengthening relations. Total trade between January to July 2021 rose 68.16% compared to the same period in 2020, with a total value of $6.8 billion. The same figure has also been demonstrated by the Australian business community, who have taken up the opportunity to invest in the health sector. As we all know, Aspen Medical and Aspen Doctor have established a partnership with PT Jasa Sarana valued at $1 billion to build and operate a number of clinics and hospitals in West Java. My hope is that the discussion held today, in addition to those convened during the first and second days of the conference, will provide greater insight on how Australia and Indonesia could increase engagement to address these existing issues. I believe that health will be at the forefront of global policymaking and engagement, at least for the next few years to come. It will require concerted and collaborative efforts for the world to emerge out of this global pandemic. Indonesia Update has always been a great initiative and enlightening platform for Australians to the inform of the current state of affairs in Indonesia. And for that, on behalf of the Indonesian Embassy in Canberra, I would like to congratulate ANU, in particular, the team at Indonesia Project for successfully convening this year's conference. And may I also inform that we will be holding our own Australia Update in October in Indonesia. Australia Update is an initiative by the Indonesian Embassy in Canberra, which commenced in 2019 with the support of the Australian government, in particular the Fed and the Australian Embassy in Jakarta. The main objective and the characteristic of Australia Update that we conducted is about spreading positivity and enhancing awareness about Indonesia, Australia, about the relations between Indonesia and Australia, regardless of the topic being raised during the update. I note that my good friend, Ambassador Kinlan, is also following to this conference. So please allow me to take this opportunity also to thank him for his support for the Australia Update that we have been conducting since its inauguration back in 2019. It would not have been successful without his enthusiasm for the event. Moving ahead, we look forward to engaging closely with Ambassador Penny Williams and her team in our upcoming Australia update. Allow me to close with an Indonesian saying about friendship. Sahabat itu ibarat bintang, dia memang tidak terlihat, namun dia selalu ada untukmu. Friends are like stars. They are not always seen, but they are always there for you. Australia is a friend that is always there for Indonesia to help us to find solutions to all the problems that we might have. We hope our friendship continues to shine brightly. So thank you once again for the convening of this Indonesia update. I wish you a successful conference. And more importantly, thank you so much for being part of the better relations between Indonesia and Australia. Terima kasih.
Terima kasih. Thank you, Ambassador Kristianto Legowo, for your welcoming remarks. And now we're moving on to the panel presentation. The first presenter is Ade Prastiani. I'm inviting Asti. She will be speaking about liberation for mental health. Silakan, Asti.
Thank you very much, Mbak Ruri, and thank you, Mas Riyandi, to help me share the screen. And so let me begin. Good morning and good afternoon, everyone, and thank you for having me here. I'm here on behalf of the Indonesian research team for Together for Mental Health, which is a collaboration between Middlesex University London and University of Gadjah Mada, which is made possible by the funding of the UKRI's Economic and Social Research Council and Global Challenges Research Fund. And apart from Indonesia, this project is also conducted in Ghana with our counterparts from King's College London and University of Ghana. Slide, nice. Okay. So let me show you an overview of what I will be discussing here. So I will discuss here a series of reflection from what we encountered in this project. Firstly is how there is a crisis in mental health care in Indonesia. Then I also reflect on what got us here, historically speaking. Then I also look into how there is a shift to developing community-based mental health care. I will explain the position that the project I took part in, which is Together for Mental Health, in these contexts, and using one observed case of a person who has been freed from Pasung, I want to summarize what lessons I have learned. So before we begin, though, it is only appropriate for us to be on the same page on what mental health is. Slide. Before we talk about the crisis, we have to understand what mental health is. So the WHO defines mental health broadly as not only the absence of illness, but as the state of well-being where a person is aware of their own abilities, they can cope with the normal stresses of life, and they can have productive and fruitful work and contribute to their community. So it's self-identity, its resilience, and its social role or position. Meanwhile, Indonesia's 2014 mental health law adds to these 3 points and defines mental health as a condition where someone can grow physically, mentally, spiritually, and socially. So, and in contrast, mental illness can be quite constricting in their definition. It is the disorders in cognition, emotion, and behavior to a significant degree that renders someone unable to attain their potential, causing suffering and challenges. Yet for a long time, it has been, mental health, a forgotten aspect of the health system, mostly because it is invisible in the way that the prevailing attitude is to leave it out of sight, out of mind. Another reason being it is not considered as one of the main causes of death. And however, while mental ill health is not the main contributor of Indonesia's death or disability-adjusted life years, but the years of life lost to disabilities due to mental health problems is greater than the sum of the top 4 diseases with the greatest burden, which are cardiovascular, cancer, maternal and neonatal related diseases, and tuberculosis and other respiratory infections. Slide. And in Indonesia, we are in a long-term crisis of care for people with mental illness. Like in the scene that we encountered in Flores, physical restraint, or what is known locally as pasung, is a gross violation of human rights, and it is happening all over the country. It worsens a person's mental and physical illness conditions too, causing muscular hypertrophy from immobility, as you can see here, and also it further deteriorated their mental health condition. It is a gross violation of human rights. Slide. And although the problem of pasung had come to the attention of the Indonesian government for over 4 decades, it was not counted in Indonesia's health statistics until recently. Free Pasung only started to become a government-sponsored program with its formal announcement on the World Mental Health Day in 2010 by the late Minister of Health, Ibu Endang Rahayu Sudianingsih. And in 2013, the Ministry of Health's Basic Health Survey first gotten us a glimpse of the pasung prevalence. And the most recent estimates are from the 2018 one, which is what I'm showing you here, with that approximately out of 450,000 people living with severe mental illnesses, around 14% of them, or around 57,000 people, have experienced pasung in their lifetime in one form or another. And free pasung then became a social movement over time, understanding the magnitude of the problem. And it galvanizes the voices of not just mental health providers, but also consumers and caregiver groups such as Komunitas Peduli Skizofrenia Indonesia, to name a few. It was one of the most powerful drivers, this movement, for a new mental health law that was ratified in 2014 that outrightly criminalizes the practice of pasung. However, in reality, enforcement of this law is hard, as oftentimes it is a communal decision to restrain someone that is considered a danger to themselves or others. Slide. The COVID-19 pandemic raises the concern for pasung prevalence, because there is a lowered access to mental health care, which contribute to the unattended needs of these patients with mental illnesses. This leads to a suspected increase of pasung practice, or even a return of a released person back to pasung. There is not yet any published data on the problem. However, as an example, you can see in this picture here, a grassroots activist, Father Afen Saur, in Flores, in Ende, found that in one of the people that he facilitated in release from pasung, who was stable enough not 2 years ago to partake in a local mental health advocacy event, was put back in pasung only months after the pandemic started. Sadly, he died in February this year. So where did we get it wrong in our mental health care? Slide. It helps us if we learn from history to understand how many Indonesian communities imagine treatment and care for mental illness. Slide. In the archipelago, since the 18th, 19th century, from Dutch state colonial administration and archives, we know that the state-based mental health care was provided in a way that was to a large degree racialized and class-based, not to mention centralized in Java. So what happened for someone living with mental illness in the colonial era? So for the indigenous population, and I use this loosely to refer mostly to non-European or East Asia populations, the principle of care is that mental illness is a family matter, and the treatment is based on severity of disturbance to others. So those who were non-aggressive, they were tolerated but made fun of. But if one was aggressive and violent, they would have been incarcerated, such as in pasung, and care seeking was done to local healers. When their condition was prolonged and intractable through indigenous healing, and if their family was able to gather enough resource, then they would be sent to hospital. Hence, hospitals was in the past considered an alternative instead. Slide. And the path to access hospital care has evolved over time too. Hospitals were assets and services mostly owned and run by the Dutch Indies military. Batavia, or Jakarta in that time, was a central point of governance, and there was a referral pattern from military bases to Batavia hospitals. And this geography of power in healthcare is still relevant to current day. There are also other facilities, such as the Chinese Hospital of Batavia or the church's hospices, that were run mostly as charity facilities. However, mostly only the company's European staff and local rulers or family or kin were beneficiaries of European hospitals, which were the stronger health system at that time. There were obvious different treatment between European, Chinese, and the indigenous population. And the path to access hospital care for non-Europeans living with mental illness was mostly through custodial care under court orders. The more facilities were built, the more it became class-based, and voluntary access was available, but for those who could finance institutional care. However, after independence and the mental health law in 1966, the right to access institutional mental health care became voluntary. Care at the hospital also experienced an evolution, and it reflects the principles of care in Europe at the time, from what Foucault said to be the Great Confinement before the 18th century, in which a custodial care mostly performed isolation, shifting to providing occupational and vocational therapy, to psychopharmaceutical therapy for psychosis disorders in the 1950s, which gives a boost to the field of neuropsychopharmacology. However, again, it was only prescribed if family could afford it. And these care in the archipelago were only available, again, to those who could access the hospitals that were located mostly in Java. Those that could not relied heavily on the use of restraints and traditional healing. Slide. For a long time, the geographic and class-based inequality of care really shaped the imagining of mental health care in the Indonesian society. Although there are signs of efforts to narrow the gap in care, inequality is still happening. In terms of mental hospitals, at the moment, Indonesia has 51 mental hospitals, consisting of 32 public and 19 private hospitals. Nevertheless, not only are we short on psychiatrists and psychologists, because in 2017, it is reported that for every 100,000 population in Indonesia, we only have 0.3 psychiatrists, 2.5 mental nurses, and 0.1 psychologists. And they are mostly still in the western part of the country. In Flores, for instance, there is only one psychiatrist who works full-time in the whole island of 1.8 million people, with one based in Kupang also has a part-time commitment flying back and forth to the hospital in Ende. On the other hand, globally, there is a recognition that hospital care is not without its harm, with practices of treatments such as forced hospitalization and the use of restraints and isolation that still overlook patients' rights. Within the confines of a hospital, the power dynamic between providers and patients can also be less than helpful. So increasingly, the goal is to shift the care out of the hospitals into the community with a recovery-oriented care that is coordinated and integrated. Slide. So how do we envision community-based care? So interestingly, in Indonesia, disasters created opportunities for this. Slide. The 2004 Boxing Day earthquake and tsunami disaster in Aceh is one of them. In addition to the huge death toll, which is 170,000 approximately, and massive displacement of 500,000 people, and the catastrophic nature of the damage, they were instantly recognized as potentially experiencing mental health crisis. And the communities on top of that in Aceh also had long-standing trauma due to decades of conflict. In the aftermath of the tsunami, local and domestic actors in Indonesia and in Aceh, consisting of psychiatrists, psychiatric nurses, psychologists, and other allies were coming together organically, along with international NGOs such as the IOM and international academics, to find opportunity for change in how mental health care is imagined, structured, and delivered. So trainings of local nurses and GPs to improve their competence in mental health care was provided. The delivery of psychosocial care at the community level, also involving psychologists, were also provided. And there were a care plan that is geared towards the patient's reintegration into the community. And there was sustainable care at the community level that was envisioned through stratified healthcare provision. It was often referred to as the Aceh model. And although the idea of a stratified referral care was already an aspirations since before then, the consolidation of factors in Aceh acts as a turning point, liberating us from the constraining imagination of a hospital-based care. Since then, there has been a change of wind to invest in building community-based mental health care. Formal community-based mental health care that is run by Puskesmas is reportedly improving vastly. In 2011, the ministry's health research, or Rifaskes, reported only 64% Puskesmas runs mental health programs. And in 2019, that figure grew into 92.4% out of 9,800 something-ish Puskesmas. And stratified system of care is now also fully covered by the National Health Insurance Scheme, JKN, which is a great modifier to access of mental health care. Yet there are still big challenges ahead. The mental health is mandated to pursue the development of mental health care under the 2014 law. However, investment is very little. So in 2019, out of the total 2.6 trillion rupiah of the ministry's national budget, only less than 1.5% was allocated for mental health. 2/3 of that is earmarked for the issue of substance abuse and rehabilitation, leaving little for other needs. Meanwhile, in real life, on the ground, actors involved in care provision also includes non-formal mental health care, which consists of traditional and faith-based or spiritual healers, among others. However, in discussing the way forward for community-based mental health care, the non-formal providers are often omitted. So it renders the position of these practitioners to be ambiguous and systematically overlooked. And prevailing sentiment about informal care is a negative one. And it is due to actual findings of human rights violation by a number of faith-based or traditional practitioners, which is indeed a travesty. But co-utilization of pluralistic care from formal mental health services and faith-based practitioners, for instance, by people with mental health needs is consistently present. Mental health survey also found this. Out of 100 respondents in the country, only 3.6% respondents accessing solely formal mental health care services in low and lower middle income countries. So if we continue to ignore it.
Another 4 minutes, yeah.
Okay.
Sorry.
So if we continue to ignore it, there is a blind spot in our gaze. And this is what, slide, our project aims to explore. Slide. We especially sought the manners in which pluralistic care can not just coexist, but also collaborate to provide care for people. And between October 2019 and January 2020, we explored these collaborative practices in 3 islands. Slide. We encountered various attempts at integration and collaboration in providing care to people with mental health care needs. And we saw physicians, psychiatrists, nurses collaborating with Islamic Ruqyah practitioner, Balinese traditional healing, that is called Balian, and Catholic priests and brothers providing care. And for today, I would like to take you to Flores to tell you a story of how pluralistic approach and collaboration has been attempted. Slide. We were following Father Andi, slide. That is a member of the Chameleon Order of the Catholic Church. It is an order that follows not only the vows of poverty, chastity, and obedience, but also the 4th vow that they will serve the sick poor in perpetuity. So since 2015, they have provided care mostly to people with living with mental illness in Pasung, in Flores, in Maumere, Sika. And he and the Chameleon Fratres would build a special bamboo and iron barred layered wall, 3 by 4 meters squared building house to patients who have been released from Pasung. And these houses are built just next to the family's house without removing them from their family. The principle behind this is that patients' healing process will be facilitated by their interaction with the social environment. And proximity to the patients over time in a more dignified setting is meaningful for their family and neighbors, as it allows firsthand experience of witnessing how their loved ones undergoes recovery. Slide. but when releasing a person from Pasung, it takes months of preparation, and it includes coordination and collaboration with the local community health centers for delivery of medical care. And on the day of the release, upon assessment by the local nurses that the patient is stable enough, the priest would perform religious and cultural ceremonies before his family and neighbors. It is called a cooling ceremony, and which involves a family elderly. In this picture is a grandmother giving blessing to the patient. And they do this because they know there is a strong need for a healing process that puts them in line with that cultural understanding, reflected in how almost all of the patients they care for have also sought traditional healing. Rather than seeing that as an obstacle, they acknowledge it and incorporate it in their care. And this is not only to ease the patient, but the family and the community, which is crucial to the sustainability of the patient's release from Pasung. Slide.
I'm sorry, Asti, one more minute, yeah?
Okay. So there are still imperfections in the delivery of care for this patient, though. Medications are not always reliably supplied in public health facilities in Puskesmas, and that really affected the speed of recovery that the patient can experience. For instance, this Pasung that we witnessed, after a year of medication, he was still experiencing symptoms of hallucinations. In addition, there is a fear of letting the person out of the Rumah Pasung house, which is counterproductive to the effort to have a recovery-oriented care. And this is because the family is fearful of the danger that he has posed in the past. So the chameleons have to be attuned to the processes and the factors that would alleviate that kind of fear. And as we were leaving the family's home, I saw Father Andy had a quick chat with one of the female relatives because he was ordering ikat weaving textile from them. And this is one of the ways that they provide livelihood support to the family of the patients they help. Slide.
Asti, would you mind to wrap up, Asti?
Slide, yes. Okay, yes. Slide, please. And yeah, slide. Slide again. So what did I learn from this? Is that the care provided by the chameleons also recognize that there are structural problems in addition to the social and cultural needs that the patients and family have. And this is a lessons learned for us. Slide. Can we go to the slide? Yes, sorry. So this is the biggest lessons that I learned from witnessing what they do, is that the mental health care that is happening on the ground continually evolves. And we have come a long way in building a formal mental health care system. However, we do still have shortages in not only the formal mental health care, but also in recognizing informal care actors. Community-based approach to solving Pasung in particular, and in mental health care in general, must respond to the community's cultural and structural context and needs, and work towards forms of care that promotes human rights and recovery. So with that, I conclude my talk. And before I end this slide, I would like to also invite you to tune into future screenings of the film that will come out of our project, Harmony, titled Harmony, Healing Together. We were supposed to have an offline film festival screening in Canberra. However, because of the lockdown that is happening, I believe it is going to be delivered. And the film festival is called This Is My Brave Mental Health Film Festival. So I invite you to partake in that event. So lastly, slide, yeah. I would like to thank you, everyone, and also to acknowledge all of the participants and everyone that have been assisting the development of this project. Thank you very much, and apologies for going over time.
All right, Asti, thank you so much. This is very important issue that quite been neglected, yeah. All right, so moving on to the second presentation. I'm inviting Dr. Muhyiddin and Dr. Jericho Pardosi, I'm sorry. Silakan Mas Salut dan Mas Jericho.
Yeah.
The screen is yours.
Thank you very much, Baruri. Assalamualaikum warahmatullahi wabarakatuh. Good morning to everyone in Indonesia, and good afternoon for everyone in Sydney and also in Australia. My name is Salut Muhyiddin. I'm from Macquarie University. First of all, we would like to thanks to the convener while I'm going to share my presentation here. So I'm going to present this study together with my colleague, Jericho Pardosi. But before that one, I would like to say thank you to the convener for the 38 Indonesian update, Mas Firman dan juga Mbak Ririn. And then I would like to acknowledge the owner of the tradition owner. We acknowledge the Daruk, the Turrbal and Yugara, the Ngunnawal and Ngambri people as the First Nation owner of the land where we work, live, and gather today. We pay our respect to all Aboriginal and Torres Strait Islanders, Indigenous people, past, present, and future, and acknowledge that this land from which we benefit has an ancient history that is both rich and sacred. Let me to start this presentation. We've been assigned to present about maternal health. So let's start this one by saying that maternal, which is coming from the root of mater, is a mother. So it's about the characteristic of mothers. So maternal and also paternal, of course, are part of the human life stages. But what usually have been described as maternal health is basically referred to the health of women during pregnancy, childbirth, and postpartum period, basically during the reproductive age period. Nevertheless, what we are going to try to convince everyone here is basically to say that the concern of the maternal health is not only the women itself for themselves, but also is supposed to be concern from everyone else, because maternal health cannot stand alone. It has to be supported by the condition they're living, whether they're starting when they're early age, and also the partner and the family. So maternal health cannot stand alone, and that it has to be kind of like concern for everyone else. So we would like to, I'm going to present about the introduction part as well as the trend from the past and present. And then my colleague Jericho going to present about the most common issues that what we face today, in particular from our study. We've been conducting some studies in the context of entity province. So that's kind of like what we're going to highlight as well. So we are going to conclude this by giving you some ideas what need to be done in the next, which is moving forward one. Okay, let me start with saying that, again, to emphasize that maternal health is a concern of society. And the good news is that at the observation level, either at the individual level, which is micro, and then at the community level or meso, but also at the macro level, at the national as well as globally, maternal health becomes one of the main issues. Say, for example, at the global context, it's been a while that the safe motherhood, for example, back in 1980s, late 1980s, when the first conference in Nairobi, Kenya, they're talking about safe motherhood program. And also after that, there is a MDG, Millennium Development Goals, back in 2000. They're trying to highlight the maternal health as the program of number 5, in particular together with universal health coverage. And then recently, when everyone else talking about United Nations Sustainable Development Goal, maternal health is also part of the health issues that have been raised. So what happened is, when at international level, they're talking about that one, it also goes down to the national level, like Indonesian context. So the government of Indonesia has also done several policies and programs focused on maternal and child health, such as family planning program back in the 70s, and then safe motherhood programs in 80s. And then we do have like Bidan Desa, and also kind of like health facility care and so on. So my point is basically, again, maternal health has become the everyone concern, not only at individual, but also community and national. Just to give you an idea about at the global level. So one of the 17 goals of sustainable development is health, good health and well-being. So maternal health has been kind of like putting into the element, not specifically like in the Millennium Development Goals, which is kind of like the goal number 5, it specifically state maternal health and universal health coverage. But maternal health is become part of number 3, because sustainable development has a lot of issues. Even this one, a lot of people still kind of like asking, where's my focus on? But anyway, on the maternal health, it's specifically, one of the goals is basically looking at the global maternal mortality ratio to try to achieve by at least fewer than 70 maternal deaths per 100,000 live births. It means if there are about 100,000 live births, it's not supposed to be about 70 people, mother, who may die because of that situation. So it certainly needs attention to the performance of the whole system. It's not only about during that delivery or during pregnancy, but it's kind of like, again, during the teenager and then during motherhood as well as the post one. And then that's kind of like the situation has been that one. So here is the figure about the maternal health at the global one, but also in the Asia Pacific context. For example, the global, the maternal mortality has reached kind of like 144 per 100,000. In the Indonesian context, is already reaching 136. The good news here is basically the trend is declining everywhere. Okay. Nevertheless, if you can see the level that we have so far is still quite high, even still kind of like very close to the global level. And then we compare with the target, is still far away. And then if we compare with the progress from the East Asia, and Oceania, is also still quite high one. And then even so, if we compare with Australian context, it's still kind of like very, very far one. According to this latest study from the Gates Foundation, most of this kind of like maternal health due to several bleeding after childbirth, infection, high blood pressure during pregnancy, and also unsafe abortion as leading cause of maternal death. So having said that one, so our presentation trying to kind of like the objective is looking at how far the progress of maternal health in Indonesian context, which specifically we are going to focus on treating. Because we know that there are so many issues in maternal health one, but we just, because of the limit time presentation here, we are going to focus on treating maternal mortality, maternal health care service, and maternal health insurance. But also, toward at the end, we are going to give some recommendation about how to move forward. So what more need to be done to ensure its faster progress? So in that one, we focus on. Let's see, the first concern about maternal mortality. Okay, so here is basically the left one with the graphic line. We presenting about the trend of Indonesian maternal mortality rate and the target by 2030 to get 70. Good news is that, remember yesterday, Pak Terry Hall talking about different data sources to estimate health. Also, one of these is maternal mortality rate. Regardless that what the data we use, the census, survey, and other thing, the trend it shows that the maternal mortality rate is declining. Nevertheless, once more time, it's still kind of like quite high. So that's kind of like the concept. But the good news is the trend is declining over time. And then the right side one with the bar chart one, we try to kind of like to see what is the level of maternal mortality in Indonesian context today as compared with others. And I don't want to say this is good news or bad news again, but we are still quite hot one. Say, for example, as compared with some Asian countries and also other countries, we are kind of like top 5 hot one after Myanmar, Nepal, and Laos. So we are still kind of like in the 177 as comparatively by estimation of this one. So another question is that like, yes, we are going still quite high one. What about the regional level? At the regional level or at the provincial level, the recent study from Lisa Cameron and colleague, just by using census, we can see here that some provinces in Indonesia are still quite high one. It is true that like in Java area or western part of Indonesia, we still kind of like a very low one. But then in other part of Indonesia, like in Papua, in Sulawesi, and some part in Kalimantan, is still quite high one. Still a variation of this one. The second issue is about maternal health. What I'm going to highlight is about the care by looking at the skilled birth attendants and also the utilization of health facility. Again, the good news, the use of the health facility is increasing, but also the use of skilled birth attendant increasing. That's also kind of like being determined by the program that in Indonesia. Remember when I said about the safe motherhood back in late 80s and then the introduction of Bidan Desa just after 1988. So that's why the utilization of birth attendant is also kind of like starting when the program kind of like progress as well. When we look at the utilization of health facility, still quite high over time in Java area as comparatively in rural, in urban area, not in Java area. Of course, in particular in Java area, but also in rural area, when we look at that one, is mostly still kind of like quite high percentage in terms of housing. And then if we look at that one, is it a good or not using the health facility? Another study conducted by Faculty Kedokteran of UGM, they just realized that the utilization of a hospital is not always a good thing, because it doesn't mean that it's kind of like guarantee when the delivery has been conducted in a health facility is going to avoid the risk of maternal mortality. In province in Java, still quite a lot of number of maternal death occurred in Java, but other provinces like in TT is still kind of like in puskesmas or even home before that one. In Papua, still kind of like the news is kind of like happening in Papua because of the place of delivery one. So the last issues about the health insurance. The maternal health insurance is not become everyone business in the past one, because we still kind of like the insurance focus on the very limited people, those who are being a civil servant, those who kind of having the private insurance and so on. So mostly people need to pay out of pocket. And the good news is that starting when the idea of universal health coverage already been on the implemented one, in particular in 1999, when the beginning of national social health insurance or ASCA scheme cover not only everyone, but also covering the poor one. It includes with the maternal health, or it includes with the access of family planning methods. And even so, by 2007, the National Security Insurance Scheme has been improved by including with not only poor, but also the near poor, because that's kind of like the biggest portion as well, the near poor as well. So that's Jamkesnas replacing ASCA scheme to cover that one. Despite increase of the coverage, however, there are still many the poor and also the near poor population have not enrolled in this national insurance scheme. So that's why some province or some regions kind of like conducting their own, we call it Jamkesda. This is just give you an idea how the variation again coming here. So before I offer to Jericho, I just want to highlight one more time that insurance or budgeting on finance is one of the elements in terms of if you want to use kind of like health facility, everyone use that one. Instead, together with health staff, equipment, supply medicine, and also the good facilities and the system. Okay, I think I will stop that one, and then I offer to Jericho.
While you're moving it over to Basilico,
Yes.
5 more minutes, around 5 minutes, Mas.
Thank you, Lori. I'll speed up a little bit. Reflecting the past and present maternal health situation in Indonesia, so we applied the 3 delays model suggested by Thaddeus and Main in the 1990s. Many of you will be familiar with these models. And just want to draw your attentions. When you look at this model, it's trying to identify any specific delays that will lead to unnecessary death among mothers or women, including their newborns and children under 5. So influential factors, for example, the first delay is about decision making. I just want to highlight the importance of women's status in the community, especially where male-dominated decision making made regardless their inadequate knowledge. And if you experience the first delay in making decisions in the scenarios of pregnancy and delivery, you will experience the second delay in reaching the health facility, mainly driven because of the physical distance, as well as the transportation's affordability and affordability, which lead to the next delay, and that is the last delay in receiving the care, or which means it's about the lack of supplies, inadequate health staff competence. And you can see there's a sequential order from the first delay to the next delay. Next slide. But we do need to have an agreement that pregnancy is not just women's business, although there's still perceptions in the community that it is women's business relating to their pregnancy and childbirth. Nevertheless, we need to acknowledge the strong influence from the community that will influence the maternal health outcomes. So in recent years, many scholars in the field of MCH argue the importance of engaging the community as the fourth delay by understanding the structural context on women's status. Next. So just to give you demographic information, if you're not familiar with Nusa Tenggara Timur province, including the distributions. But when you look at the map, you will notice the geographic challenges for accessing not only maternal health care services, as well as other services in timely manner to the next level of services, for example, the district and provincial hospital. Now, this slide just to show you that since 2009, the entity province office promoted what they call Revolusi Kia or MCA revolutions, trying to ensure that all women give birth in adequate health facility, especially on the red zone. Even they come up with a very nice lyric song saying, you can come as one, as a mothers, to the health facility, but after delivery, we need minimum 2. 3 is better, but not 1, because if it is 1, which means either the mother die or the newborn die. So nevertheless, looking at this journey of women, our empirical studies show that most women worried about their past experience with the healthcare providers, out-of-pocket issues, as well as presenting themselves to the clinic with new clothes and clean. Next one. So both graphs highlight the strong influence, TBAs, yes, it still exists, because of their extensive services compared to midwives. As mentioned earlier, the entity already released their MCH revolutions. It makes a huge impact. Nevertheless, it's still based on the recent data, 12 to 15% of home delivery with TBA assistance. Now, let's just focus on, in 133 seconds, first delay, mainly about the lack of awareness, as well as home birth, which is considered as to be less disruptive and less costly. So the idea right now, how about men's involvement during pregnancy and childbirth? How about women's status? Because you cannot reject the reality TBAs plays an important role in home deliveries because they provide such an extensive services, including emotional support to mothers and the rest of the family. The second delay, decision making. Yes, but second delay is more about difficulty with economic and physical accessibility. Dr. Salut will play a little bit just to show you a few seconds, probably, Pak Salut, if that's possible.
Okay, just a few seconds.
Just a few seconds. Just to give you the kind of the contextual situations in entity province, which is predominantly living in rural areas around 80% of its population living in rural and remote islands. So moving on to the next one is the third delay. On the third delay, it's more about the availability, the quality of care. Do we have doctors? So the questions right now, even do women aware about their maternity care rights? Now, the graph suggests the discrepancies. Even in the capital city, there are still mothers who had home birth, regardless the short distance to the closest health facility. I'm going to conclude in the next, two slides, if possible. And this is just to show you the importance of engaging community. And I'll head over to Pasalo to give kind of a closing suggestions moving forward.
Thank you, Jericho. Sorry, everyone. Just want to closing up this one by saying we need to go moving forwards by having Ibu, because Ibu means mother. So the first Ibu means improving the quality of maternal health care service. B, building trust between communities and healthcare providers, and U, understanding women's rights and needs by ensuring access to all women and their autonomy. I think I close with that one. Thank you very much.
Okay, thank you so much, Mas Salut and Mas Jericho. Now we're moving on to the third speaker. We have Dr. Diana Contreras Suarez. Apology for mentioning wrongly your surname, Diana. And Diana will be speaking about disability in Indonesia. Please, the screen is yours.
Unmute. I should unmute. Oh, sorry. Okay. Thank you. So thank you everyone for this great presentation. I really want to start by thanking the organizers of this conference. It has been really good and I really have enjoyed all the sessions, and thanks Ririn and Firman because you have done a really good job and all the team organizing. And I wanted also to say that I feel very encouraged, and it's really close to my heart, the fact that it's the first time I come to a conference and there is sign language interpreters. And this is very relevant to this particular talk that I am going to present, where we are trying to give the opportunity to all the segments of the population to participate in discussions like this one. So this was work that we did together with Lisa Cameron. We both are from the University of Melbourne, and an early version of this work was funded by DFAT. So I'll start by saying that in 2011, Indonesia signed the ratification of the UN Convention on the Rights of People with Disability, and that was the first comprehensive human rights treaty of the 21st century. And the main aim was to change the attitudes from viewing people with disabilities as objects of charity, medical treatment, and social protection towards seeing people with disabilities as subjects with rights. I think in the update in 2019, there was a big session on disability, so I'm not going to go into a lot of details of the discussion, but my summary of what that meant for Indonesia was that the government committed to eradicate the discrimination against people with disabilities, actively work to support and provide services to the segment of the population, and also to be thoughtful on providing public programs to be inclusive and accessible for all people with disabilities. As a result of that, in 2016, Indonesia passed the law number 8. And as a result of that, then the main challenges that were presented to the government was, one, to learn how many people do they needed to prioritize, so how many people do they need to serve, and also what was the magnitude of disadvantage for people with disabilities. So what I would do in this talk would be, first I would provide a context of what do we understand by disability. I will give a description of the proportion of people with disabilities in Indonesia. And for that I will use several sets of data sets available at the population level. Then I am going to provide some differences in different areas between people with disabilities and people without disabilities. And then I will also compare the families of those people with disabilities with families that don't have a person with a disability. So what is to be a person with a disability? The answer to this question is quite complex. So we can think of what does it mean if a person is unable to walk, does she or he has a disability? What if their inability to walk is only temporary? Or if they are unable to walk long distances, but they are okay with short distances? Or what happens if they cannot use their legs, but they have a wheelchair and they are very able to go around? Are they people with disability? And because this is a difficult problem to solve, the most current thinking on disability integrates the medical and social model framework, which was called the International Classification of Functioning, Disability and Health, introduced by the WHO in 2001. And basically what it proposes is the interaction between the health condition and the environment is what limits the function, what defines disability. So in the example of the person with the wheelchair, if this person lives in a town with many streets and buildings that are not wheelchair friendly and there is little public transport, they will have a severe difficulty moving around, and therefore we are going to think that they experience a severe disability. But if in contrast, this person lives in an area where the streets are smooth and the buildings are wide, have wide doorways, and there are ramps and elevators, and buses have wheelchair access, then they might experience only mild difficulty moving around. As a result of this change on the definition, and in order to allow cross-country comparison and also tracking progress a long time, the World Health Organization also proposed the Washington Group for Disability Statistics, which the main goal was to produce a short questionnaire where countries would be able to measure easily how the level of disability. And the aspects that they decided to consider was these 6 questions, which is difficulty seeing, even if wearing glasses. So this second part refers to what is the environment that surrounds the person with a health condition. Difficulty hearing, difficulty walking or climbing steps, difficulty remembering or concentrating, difficulty with self-care, and difficulty with communication. And then depending on what were the answers, then there were 3 domains that were suggested, which is a person having no limitation, a moderate or a severe limitation. So then for this study, what we used was this set of data sets. So what I highlighted here in pink are the ones that I am gonna refer the most. And the most important that we use is the population census in 2001. The main reason for that is because in this data set, the function model definition was the one implemented following the Washington Group. And then we use other set of data, other surveys that are representative of the population. But as you can see, there are changes in the definition, even within the same survey. But I am going to present data from 2012 and 2018 just to see kind of how things have been changing across time. To start with the prevalence of disability, we observe that there is a lot of variation, given that defining disability and measuring disability it's itself very complex. But what we can see in general is that there are these 3, these 3 segments. This first one refers to all of the surveys that were using a health definition of disability. Then we have this here in the middle where they are using kind of a functioning disability definition. And then more recently, we have a higher proportion of people with disability. And this is due to the incorporation of the functioning, the Washington Group definition, and also some medical definition. But also it could be explained by changing on the way that people perceive what disability means. I like maps, and I was very happy to see one of our maps in the previous presentation. And what we did here is to show what's the prevalence of people with disability by provinces, that's what we see is that there is a higher proportion in the Sulawesi area, in Nusa Tenggara, and also in West Sumatra. However, if we look at just the number of people, we are going to see that most of the people are concentrated actually in Java, in North Sumatra, and in South Sulawesi. Most of what people reported are finding difficult. Most of the disabilities are related to difficulty seeing, but the majority of these reports are just moderate limitations. When we look at what were the cause of disability, what people report that they thought was the cause of their disability, what we see is that only 17% are congenital, and all the other causes, which is dominated by diseases, are other kind of environmental conditions that are contributing to the development of disabilities. And then in this graph, what we did was to plot the prevalence of disability over the age cohorts. And what we see is that, for example, for the younger cohort, the prevalence is very small. This is only 2%. And as people go older, then the prevalence of disability starts to increase. So once you get to the population that is 60 or more, about 50% are reporting having a disability. And although the majority are a moderate limitation, still it's quite significant, which is just telling us that this is also related to aging. So when we compare what's the outcomes for in different domains between people with disability and those without, we find that, for example, people with severe disability has on average 4 years less than people without a disability. We also find that for children who are in school age, only 32% of children with severe disability attend school compared to 79% of children without a disability. We also find a higher prevalence of the proportion of girls with moderate disability who are experiencing child marriage. And this is true for when we define child marriage as getting married under the age of 19, which is the current definition of child marriage, or even if we look at the previous one, which was getting married before the age of 16. We also find that they are less likely to work, but we have observed an increase in the proportion of the adult population with disabilities who are participating. And we found that in 2018, 42% of this population was participating in the labor market. In terms of health problems, we found that people with disability have more than double chance to self-report health problems than people without disabilities, which means if we proxy the report of health problems as a health status, that what we observe is that they are more likely to have poorer health status. They are also less likely to seek or receive outpatient care, and they are more likely to receive inpatient care, which just might suggest that people are not getting the care that they need, and then only when things become very critical, they go to the hospital, and that's why we see a higher prevalence of hospitalization. We divide this across age cohorts, this analysis, and what we find is that when we plot health complaints, we see that this follows a U shape, which is telling us that during childhood in general, children are gonna be more sick, and this decreases as people move into adulthood, and as they get older, increases again. We observe that there are kind of two regimes. One is for people with no limitations, which is lower. And then for people with disabilities, we find that is higher, and it increases more for those who have severe limitations. That would suggest that these particular segments would require more access to healthcare. So then we plot, what's happening? Sorry. So then we plot here what is the access to health insurance, and we find two things. One is that if you look at the levels of comparison between those who have no limitations, moderate or severe limitation, there are no significant changes, which suggests that access to health insurance is not considering the health or the disability needs of this particular segment of the population. But also what we find is that for the younger cohort, where most demand it's probably prevalent, is where the lowest access to health might exist, given that the access to health insurance is lower. When we look at the participation in rehabilitation services, we find that it's very inexistent. So 94% of the population report having no access to any of these rehabilitation services. When we look at what happened with the families, of those people who live with a person with a disability, we find that in general for children, there are very small differences. So there is just a small proportion of children who are not being breastfed because there is a person with a disability in the household, or school attendance is also not different. What it was particular was child labor, that there was a higher likelihood of children being in child labor. And this could just reflect the fact that there is time constraints by probably the mother, which is more likely to be the caregiver of the person with a disability, especially if the person has a severe disability. So then children were more likely to be working. When we look at the main caregiver, for female-headed households, labor force participation was lower, which is just showing that in those particular household compositions, the women is taking care of the person with a disability, and it has to decrease the time that they spend in productive activities, and therefore is more likely to have lower levels of income, which is then reflected in the next point, which is where we find that the monthly total expenditure per capita is lower for families with people with disabilities, and even lower, 21% lower for those families who have people with severe disabilities.
More minutes, yeah, Diana, sorry.
Yeah, I'm almost done. So households with person with disability also have less wealth. They are more likely to be food insecure, and they are more likely to receive a social security that are targeting the bottom 20% of the population. But also they are less likely to receive social security, which is related to better employment opportunities. So they are less likely to have jobs which have work accident insurance or life insurance. So in summary, what we find is that people with disabilities, lower education and training, they have lower health status, they have limited access to services and infrastructure, and therefore they have lower economic opportunities. We also find for those families, they have lower labor market participation. They also have, that's even more prevalent for those households where the woman is the head of the household, and that also lowers their household expenditure. This, what it's going to represent is that those families are going to have a greater risk of poverty. Although it's still not clear whether poverty is a cause or a consequence of disability, that means we don't know if it's because people are poor, then they are more likely to develop a disability, or the other way around, which is they have a disability and therefore they are poor, although we don't know how it is. What we find here very clear is that they are very highly correlated, which just kind of take us to the challenges for Indonesia and the opportunities for Indonesia. Thus, as it's moving towards implementing the law number 8 of 2016, they need to move towards improving adequate education, access to education for people with disabilities, improving the social protection program to support families with people with disabilities, and to the extent that the current coverage is doing that is not clear. Improving also access to economic opportunities, and also improving access to appropriate healthcare. And as we observe what were the causes of that people reported to develop disability, we saw that injury and disease prevention that leads to a disability should be something that it needs to be considered. Also, early diagnosis and intervention to reduce the severity in the long term would be important. And we know that this would be cost effective in the long term, as preventing is usually cheaper than curative care. To finalize, I also want to emphasize in the need to improve data availability for monitoring the progress of people with disabilities, and also to be able to assess how Indonesia as a whole is moving towards this aim of increasing the participation of people with disability in the society. That's it. Thanks.
Thank you, Diana, for being on time. Thank you all for the great presentations, three of you. Now let's move on to the question and answer. So we have maybe 2 or 3 rounds. For the first round, I cannot open my video. The first round, we have Aliza Han, which will deliver her question live. And then second, we have Vivek Nilakantan. I will read one of the question. And also the third one, we have Ais, who will also deliver her question live. Okay. While waiting Aliza and also Ais to prepare asking question live, I would read the question from Vivek Nilakantan. Sorry, I'm going to read one only. The question is for Ade, for Asti. The question is, I would like to know more about what was different from psychiatry in contemporary Indonesia from that of the preceding colonial period. Perhaps you could elaborate it a bit more.
Thank you very much, Mbak Ruri and Vivek.
Yep. Maybe we ask everyone to ask the question and then have the presenters answer it. Yeah, Ade.
Okay.
Okay. I will ask now Aliza to open your microphone.
I have indeed. Thank you.
Okay,
thank you, Mbak Ruri, and thank you to all speakers. I've got a couple of questions, but I'm only going to ask one in the interest of time as well. My question is also to Mbak Asti. Thank you. Fabulous presentation as always. Given the high numbers, we're looking at the equivalent of the Australian population suffering from clinically relevant anxiety and the incredible burden that you talked about, years lived in disability caused by mental illness in Indonesia. I'm just wondering aloud why mental illness has remained virtually invisible at the national policy and research level. I'm wondering if you might talk a little bit about what's happening to these vulnerable populations, for example, Pasung survivors during the pandemic.
Okay, terima kasih Mbak Aliza. Now I'm inviting Aisari to deliver a question. Silakan Mbak Ais.
Good morning, Bu Ruri. Thank you for the opportunity. Good morning, everyone. I'm Ais from Center for Health Economics and Public Policy, Universitas Indonesia, and I would like to ask Jericho regarding your research finding that you already present. How is the effective of maternity waiting home in order to reduce MMR and also infant mortality rate in NTT? Is it appropriate intervention to shorten the referral time from mother's house to the health facility that we can prevent the also? So if is it the appropriate intervention, is it good if we accelerate the implementation, or should we modify in some part of the implementation of the program itself?
Okay, thank you, Mbak. Sorry, one question only, yeah, per person.
Okay,
right.
Thank you. Yeah.
Thank you, Mbak Ais and Aliza and Vivek. Please, now I inviting Asti to answer the question.
Thank you very much. I was a bit impatient to answer that at the beginning, so I apologize. And thank you very much for the question from Vivek and Aliza. Really great to hear from you again. And Vivek, for your question, and I believe that probably you're even better equipped to answer this as a historian of Indonesian medical field. I what I know about the differences between psychiatry in contemporary Indonesia and what it was in the colonial era was predominantly the composition of the psychiatrists themselves. In the past, obviously, it was more so health workers were mostly those that were from the colonial government, especially those in power. So psychiatrists were mostly European, of European origin, and that created some sort of challenges in connecting with their patients. It will be linguistic barriers as well as barriers in culturally understanding the belief systems and the expectations of the patients that they're trying to serve. And that is challenging. And since the mid-19th century, obviously, since the advent of medical education for native medical doctors, it has started gradually to overcome those challenges because simply because of the ability to translate concepts in psychiatry into local languages, such as even the translation of psychiatry into kesehatan jiwa, which is an interesting concept in itself because jiwa means spirit, and that really tells about how the local understanding has a spiritual or undertone to understanding mental health. I think that's one of them. In addition, the number of schools that are now providing a psychiatry education has increased, and with that, the number produced for psychiatrists has increased greatly, and that has created a lot of opportunities to interpret how psychiatry is practiced, and including transcultural psychiatry as well as community psychiatry. And this is also supported by the global movement in transcultural psychiatry, which pushes learning of local contexts in delivery and trying to incorporate that in like bigger practice in psychiatry. Probably there are a lot more answers to that, and there will be opportunities for this to understand that better later on. And for the question from Aliza about what is happening with Pasung survivors during the pandemic, this is where data is really scant, and one of them is because of the higher reliance of care for Pasung survivors that is community-based, which requires people to go and do home visits, and that is really impacted during the pandemic. And that is why in my presentation I also said that it's really a challenge for us to envision if we are having increasing number in Pasung. Even before that, as you also know, as someone who's working on the topic of Pasung yourself, the number that is reported for Pasung is always kind of questionable, just because of the rate of repasунgisasi, putting people back in Pasung, just because of the lack of continuity of care. In the community, why there is an underinvestment. I think that's a systemic problem that is not only faced by mental health care, but also in other. But it seems like there is a competition. It seems like there's an imagined competition between healthcare programs, because when I was still practicing in Puskesmas, mental health program was an optional program. It was not the what they call compulsory Puskesmas program. So in terms of popularity in funding, there's obviously a deficit just because of that notion that mental health care program in Puskesmas is optional. But I think that is also slowly changing, as well as with the investment from the Ministry of Health in training primary care providers in mental health care. Maybe that doesn't answer your question, or it does. But also, I just want to add that there will be more conversations about this in the event that Aliza is holding on the 14th of October. So,
right, so you can continue the discussion in the event. All right, thank you so much, Asti. Now, Mas Jericho or Mas Salut, silahkan.
Yes, thank you, Maruri. Thank you, Wis, for your questions. And I'll also invite Pasal to add further comments. When you're looking at the global evidence historically, actually, this is going back to Europe, going back to the maternity villages back in the 1950s. Yes, it's effective. Maternity waiting homes, also known as rumah tunggu, is effective by considering you want to prevent unnecessary death, especially because of the delay in making decisions and delay in reaching the healthcare. As shown by that video in a few seconds, you can see that one, the kind of dangers and the kind of situations, complex situations. If you live in rural or remote island where you have to travel for 6 or 7 hours just by boat, just to reach the village health office post, not just puskesmas, but I'm just talking about the village health post. And that's why we do need rumah tunggu, just kind of to minimize the distance gap. In our study, we didn't kind of measure the effectiveness. We're trying to investigate the effectiveness of Revolusi Kia in terms of their motto, you can come one, but you cannot come back one. You need to come back at least 2. So that's kind of my initial comment on that one. Obviously, we do need to modify, and I think Pasal will happy to add more comments on that one, Pak.
Is it okay, Baruri?
Yeah, maybe briefly, Pak.
Okay, just briefly. Yes, in the case of Nusa Tenggara Timur, the determinant is so complex, in particular culture, budaya. Having waiting house or rumah tunggu is also sometimes for the community, it's kind of like feeling them kind of like this has kind of like another hospital. So they're thinking about who's going to take care of their family left behind, who's taking care of the everything. So the culture needs to be improved as well there. So, but it is has effective in one or two the other way. But it varies from one district to the other. Maybe that's the additional. Thank you.
Right. Thank you, Mas Jericho and Mas Salut. Let's move on to the second round of the Q&A. So we have 2 questions from first Bu Tuning and also Pak Wasusilo, and both of them are directed for Diana. I will read question from Bu Tuning, bear with along. I enjoy your presentation on disability. I've been using analysis the prevalence of disability from Census 10, Intercensal 15, and Susunas 2020, using indicators from questions using Washington Group Disability Statistic. I'm trying to estimate the prevalence of older person who need long-term care. I have a problem with overlap between one and other indicator, like those who are unable to do self-care and inability to memorize or concentration. Meanwhile, estimation of long-term care is highly needed to estimate the cost of LTC, which is increasing due to increase in life expectancy. Do you have any idea on how to help with my problem? Thank you very much. And then I'll read the second one, Diana. From Pak Wahyu, we have just finished a policy paper on the intersection of labor migration and disability in the framework CRPD implementation. Several interesting findings regarding the rights of persons with disabilities to work abroad and persons with new disabilities due to work accidents. The problem faced is that the policy on labor migration has not responded to the rights of persons with disabilities. I think this is more of comments, I don't see a question here. Yes, please, Diana, would you like to respond to that? Can you follow? Sorry.
Yes, thanks. So I'm going to comment on the second comment first, which is the long labor migration, which is, I think one of the difficulties with long migration or many other areas is that regulation is hard because it's hard to identify who fits into the category of a person with a disability and what are all the practices that could be put in place to prevent and to make sure that people have once things happen. And that's not only from Indonesia, but for all across the world, especially in developing countries. The first question, I'm not super sure I understood the question. So I understood that it's kind of a technical problem when he's trying to estimate what is the long-term care need, and how do you classify people who have memory limitations in memory and limitations in self-care? Is that the question?
Yeah, there's overlap between one and another indicator, like those who are unable to do self-care and inability to memorize of concentration.
Yeah, well, I look at those overlaps between the different domains, and there were a lot of overlap between them. How do you quantify how much care does it require? I just think it depends what are the assumptions that you are making in the type of care that, in the long-term care that they will need. If they overlap, I will assume that it requires more care than just someone having helping someone to have a bath or to feed them, because this is kind of sporadic. But if you have memory, more problems with memory, it also depends on the intensity of it. I'm happy to have a chat outside the conference to understand better the problem. Yeah.
All right, thanks, Diana. So this is quite technical. So Bu Tuning, if you would like to email Diana directly, we will. Diana, would you mind to share your email? And then we will forward it to Bu Tuning.
I'll put it in the chat box.
All right, thanks so much. We still have a bit of time, and I will read question, but it's actually being addressed by Mas Jericho, from Aksari Dewi, and also Sariratri, because from Aksari Dewi has already been addressed by Mas Jericho. I will invite maybe Sariratri. Would you like to ask your question live, or?
Yeah, thank you so much. Can you guys all hear me well?
Yes, we can hear you.
Thank you so much for the presenter. All of the presentation were very amazing. And my question is related to the relationship and the roles of midwives in trying to decrease maternal mortality rates in Indonesia, and especially in Nusa Tenggara Timur. What do you see? How do you see the roles of midwives actually in trying to decrease the maternal mortality rates in Indonesia, and what relationship do they have currently with Dukun Bayi, especially in relation to Revolusi KIA, where birthing at home is discouraging, if not criminalized. I'm also doing research about similar project also in Manggarai, where Dukun Bayi is sort of criminalized for helping mother giving birth at home. Thank you.
Thank you so much, Mbak Sari. Silahkan Mas Salut dan Mas Jericho.
Silakan Pak Salut, if you want to answer, or myself.
Because thank you very much. Yes, it is true that the relationship between Dukun Bayi and also the midwife is quite long process. Remember when before there is a program of Bidan Desa, Dukun Bayi become the first priority, the first front line who's taking care of that one. And then in the context of NTT, they like this is become like more intimized. So they feel like Dukun Bayi part of the family. So not only like looking them as like very modern professional with the uniform, but they feel like, oh, you're my part family, including with massage, pijit, everything. They got that service one. However, when the Bidan Desa program started, so that's kind of like the starting, the government say like, oh, you have to go to Bidan Desa. And then Dukun Bayi role has been less one. But some places, they still kind of like combining that one because they do realize that the community still like to have with Bidan Desa. Maybe that's from my side.
If I can just add, Marie, just for a second. In recent years, after they release or initiate the Revolusi Kia, what they've done, the government, they work with the TBAs and call them not TBA anymore, but call them as cadres, as Mitra Bidan. So to some extent, they actually acknowledge that one and then feel kind of, being part of the healthcare system, which is also important for the funders to recognize themselves. So in the future, I would say a village midwife is still important, but we do need the local village midwife who understand the language, who understand the culture and the traditional customs. Thank you.
Okay, thank you so much, Mas Salut, Mas Jericho. I think we're right on time, and that's we reached at the end of the panel presentation today. So I would like to invite all to give applause virtually for the three great presentation today and also great questions from the audience. I would like also, there's a iklan lewat ya. This is message from the committee. So after this, we will have a 70-minute tea break because we have a Friday prayer. And during the break will be, there are several breakout rooms where speakers and attendees can virtually mingle. And the link will be provided in the chat box, which I haven't seen it or have. All right. So that's it. That's the link. Again, I would like to thank Ade Prastiani, Mas Salut Muhyiddin, Mas Jericho Pardosi, and Diana Contreras Suarez for all great presentations. And thank you all and have a good day.
Selamat sore, good afternoon everyone. Welcome back to the sixth panel in the ANU Indonesian Update today. My name is Helena Soisa. I'm a journalist with the ABC, currently working in Asia Pacific newsroom based in Melbourne. And it is my pleasure to chair this panel today. I'm not alone. I'm here today with colleagues from IndoSpeak. Ada Mbak Mada Ramadhani, Mbak Silva, dan Mas Takin. They will be interpreting this panel to Bahasa Isyarat Indonesia. Firstly, I would like to acknowledge the traditional owners of the land where I live and work, the Wurundjeri people, and I would like to pay my respect to the elders in the past, present, and emerging. Now, in this panel today, we have two speakers who will discuss public procurement and private markets, the political economy of healthcare professions. It is my great honor to introduce our two prominent panelists for this session. Firstly, Bapak Andreasta Meliala from Universitas Gadjah Mada, Yogyakarta, who will present his paper, The Tale of Two Policies, Political Economy of Hospitals, Medical Specialists, and the Role of Private Sector. Pak Andreasta Meliala is a medical practitioner and works in primary health care. He received a master's degree in hospital management graduate program from UGM, completed his other diploma on public health in Leopold Franzen University, Austria, and the master in advanced science Medizinische Universität Innsbruck, Austria. Dr. Meliala obtained his doctorate degree from the School of Public Health, Faculty of Medicine, Universitas Gadjah Mada in 2015, and he is now serving as the Director of Hospital Management, Public Health Graduate Program, as well as the Director of Center for Health Service and Management, Faculty of Medicine, Universitas Gadjah Mada. He is also currently the Technical Advisor of Provincial Health Office of Yogyakarta Special Territory Province. Secondly, we have Ibu Elizabeth Pisani from the George Institute for Global Health, who will present a paper she wrote with her co-authors, Pill Pushers, Politics, Money, and the Quality of Medicine in Indonesia. Ibu Elizabeth is currently leading research that uses economic and market indicators to to predict the risk of substandard and falsified medicines in national supply chains, and is collaborating with Badan Pengawas Obat dan Makanan (BPOM) and others to try out methods for estimating the prevalence and impact of poor quality medicines in Indonesia. She is a visiting professor at the Faculty of Pharmacy at Universitas Pancasila in Jakarta and holds honorary posts at Imperial College London, King's College London, and the George Institute for Global Health. She holds a PhD in infectious disease epidemiology and a Master of Science in medical demography, both from London School of Hygiene and Tropical Medicines, and absurdly, I love this one, an MA in Classical Chinese from Oxford. And I would like to also introduce Ibu Elizabeth Pisani's co-authors who will be joining us in the Q&A session. They are Komang Triaksari Dewi from the George Institute for Global Health. We have Amalia Hasnida from Erasmus University Rotterdam and Relmbus Billiers Vanda from Erasmus University Rotterdam. You can find their bios on our program book. Each topic will be discussed for about 20 minutes, and then we will have a combined Q&A session for another 20 minutes at the end. There are different ways you can participate in the Q&A session. You can using the Q&A box or clicking the raise hand icon on Zoom, and audience on YouTube can write their questions in the comment box. So without further ado, I would like to hand over to the first panelist, Bapak Andreasta Meliala. Pak Andreasta, silakan, the screen is yours.
Yes, thank you, Helena, for chairing this session. Good afternoon, everyone. My name is Andre Meliala from Universitas Gadjah Mada, Indonesia, and I've been assigned to present about the private sector and also medical specialists in Indonesia. Please allow me to share my presentation. I hope it's already there. Yeah. So I put the title of Tale of the Two Policies because we will explore this two kind of policy in Indonesia. This is the outline. I would like to start with the need for evenly distributed medical doctors because of the implementation of universal health coverage in Indonesia. And I would like to explain a little bit about the setting, the current setting of Indonesian health system. And also we will explore a little bit into deep about the policy of private sectors and also the medical specialist production, and then discussion and conclusion. So I will embark from this point that since WHO urged all the countries to implement universal health coverage, and then the issue of distribution of medical doctors is really a challenge in several countries. As you can see from these figures, that Indonesia is still in the light blue color, which means that the distribution of medical doctors is still unevenly. And then if we take a closer look about the demand side, since 2014, when Indonesia started to implement the national health insurance system, which is actually the universal health coverage, the total number of the members up to 2020 is around 222 million people. And if you see the growth over here since 2016 is quite a huge number. Maybe this is the biggest UHC members in the world. And then the principle of the UHC in Indonesia is based on the managed care. And all the members, they should pay the similar premium anywhere they are. And also they will get the same benefit for any areas. And one of the most important rules in the UHC in Indonesia is there's no co-payment. So the member, they don't have to pay additional payment when they receive services in the hospital. And when we take a look at the supply side over here, and particularly in this information, the medical specialists in Indonesia, this is based on 2017 data, we have around 54,000 medical specialists, but only 4% of them who work in the rural area. Although in Indonesia, definition of rural area is quite broad, but most of the areas in Indonesia can be defined as rural. And this is the supply side, particularly about the medical specialist availability. And then what is the result? So I just pick up one case here about the heart disease. And from these figures, you can see the direction, or they pointed out to a certain hospital in Java Island. It means that a lot of heart disease cases in any provinces outside the Java Island were referred to the big hospital in Jakarta. And the main reason, because of there's no medical specialists available to treat this level of heart disease. And then we take a closer look at the policies that Indonesia is trying to open the market of the healthcare sectors. And for foreign investment, we have presidential regulation number 44, the year of 2016. This regulation is quite interesting because for foreign investors, they can have up to 67% of the shares. And if they are from Asian country, they can have up to 70%. This is quite an open market compared to other policy in the region. So with this, through this regulation, the government invites a lot of foreign investment to open the hospital business in Indonesia. The other policy is that the government try to open more medical schools, and this is the objective is to enhance the production of medical doctors. And up to today, Indonesia has around 91 or 92 medical schools. And hopefully we assume that with these two policies, we can reduce the disparity of the health services in this country. And we can now see the impact on the hospital growth. So because of the national social health insurance system, then we have one big single payer in Indonesia called BPJS. And this payer, this national payer, they have the partner from around 2,600 hospitals, and 62% of them are private hospitals. So we can see that the BPJS partners, most of them are from the private sectors, and the rest comes from the government hospital, central level, and also from district level. This is quite a huge number. 62% of the partner is from the private sectors. And then in terms of private foreign investment, and when we still remember about the regulation in 2016, it was enacted in 2016. And then afterwards, we can see that the growth of the private investment in Indonesian health system. The countries, Australia, I think it's number 2 over here with 53 million USD investment in the Indonesian healthcare. And Singapore is the very dominant in the investment. Yeah. And the result is like this. We have the number of private hospital. The growth is quite fast for the private hospital. And even in 2018, we can see that the public hospital already outnumbered by the private hospital. And then if we try to look at the series of the growth from 2012 up to 2020, we can see that in Java over here, the most of the private investment is executed. Then we can see only in North Sumatra, the investment is quite also high. But from other region here in the eastern part of Indonesia is still low. And then if we compare the public and private hospital, this is based on the data in 2020, we can see that the highest graph over here, they are from the private sectors, and the public hospital is quite left behind. And when we also try to look at more deeper about the availability of private service in rural and urban areas, so we have the data of 2021 over here, that private hospital in the rural area is only in the tips, on the tips of the graphs. And this is only a small number. So based on this data, we can see that most of the private hospital, they run their business in the major city or in the Java Island. And then now we take a look at the medical specialist distributions. And we have a data from 2018 and 2020. The medical specialist to population ratio actually is decreased because of the increasing number of population rather than the medical specialist itself. And in rural and urban area, we have also the same figures with the private hospital, that medical specialists in rural area is only in the tips of the graph. And it means that the availability of medical specialists in rural area is quite low. And from the figures on the right side, this is the Java Island. We can see that the ratio is quite high, medical specialist to population ratio, but in the eastern part is low. So it remains the same with other information from the previous years. And we can call it that the dynamic of medical specialist distribution is not so high, or we can see that this is from this data, it is stagnant. And this is to give illustration about the coverage of medical specialist services. I compare my hometown Yogyakarta and North Maluku. In North Maluku, the 136 medical specialists, they serve, or they have to cover around 31,000 square kilometers. Compared to their colleagues in Jogja, they are 2,380 something, and they only cover around 3,100 square kilometers. So we can imagine the situation in the eastern part and also in Java Island. And this is the pattern when we take a look at these two data about the private hospital in rural and urban, and also medical specialists. It's quite the same. Why? Because the medical specialists, they refuse, or they don't want to go to the rural area if there's no hospital, or the hospital itself is not well equipped with standard equipment to support their professional jobs. So in certain areas, though they have a hospital, but sometimes the medical specialists, they won't come because of the availability of the equipment, and also other medical specialists. For example, the surgeon, they have to be there with the anesthesiologist, but sometimes the surgeon, they are on their own without their partner from anesthesiologist. And this is a discussion. The private sectors are only interested to build hospital in major cities. Why? Because they try to get closer to the market, to the population, and they invite the public medical specialists to work in private sectors. So based on the regulation, medical specialists in Indonesia, they are allowed to work in 3 places despite of the sectors. So they can work in public and private sectors in a maximum 3 places. But if the regulators, the district or provincial health office, give them special privilege, so they can work in maybe 5 or 6 places. And also the intention to do the business in the highly populated areas, because they want to serve more BPJS member. If they have a good partnership with BPJS, it means that the supply of patient will be continued. So this is about the business interest and intention. The other thing is about the foreign investor are not allowed to build hospital in the rural area. This is stated in the policy, the presidential regulation that we discussed just now. And the foreign-owned hospital are not allowed to build a general hospital, so they have to build a highly specialized hospital. So this is once again the question whether this policy enacted to closing the gap, or just to invite the private sector and do the business in the major cities or in the highly populated areas. So we are not clear with the objective of the policy. And then the other thing is the foreign medical specialist is likely impossible to work in Indonesia, because from the regulation of the government and also the Indonesian medical associations, the high-level consultants, and if the purpose is for technological exchange, so they can work in Indonesia. Other than that, they cannot work in Indonesia. And in terms of production of medical specialists, we can see here that medical specialists are only produced by public medical schools. Although the School of Medicine are mainly dominated by the private sectors, but none of the private sector can produce medical specialists. And the capacity of production is limited despite of high intention of the GP to be a medical specialist. So in Indonesia, in average, we produce around 13,000 GPs per year. And most of the residents are now independent. And the policy of the government to have kind of obligation for medical specialists, the new graduated medical specialists, to work in the rural area is already canceled. And the distribution of medical specialists is closely related to the distribution of the hospital. This is a very logic. And because of the possibility to do dual practice on moonlighting, this is encourage the medical specialists to work in both sectors. And what is the final impact? We can see here. I just put one medical specialist, internal medicine. Their availability in both public and private hospital. From here, we can see that most of them are working in the private sectors, although their status actually is a civil servant. So in conclusion, the policy to open the market actually is not really effective because of the business interest and intention is not aligned with the situation or the context, and also objective of the policy is not really clear, yeah. And this is also discouraging the foreign doctors to work in Indonesia because of a lot of requirement or conditions. And also to open more medical schools, actually just produce more GPs or medical doctors, but not the medical specialists. So we can see there's a bottleneck over here because the intention of the GPs to be a specialist is not really well accommodated. And also the maldistribution of hospital and medical specialists, we can see it is happened in a lot of areas in Indonesia. And the result, the disparity is increased rather than a decrease. So I would like to end my presentation over here. Thank you for your kind attention. Thank you, Elena.
Terima kasih, Pak Andreasta. Tepat 20 menit. Thank you. Thank you so much. It was a very great presentation and thought-provoking. I believe we will have very much questions after this, but before we're going to Q&A, we still have one speaker, Ibu Elizabeth Pisani. Kalau kata orang Indonesia, waktu dan tempat dipersilahkan. The screen is yours, Ibu. Silahkan.
Thank you very much. I hope I can share my screen with you. Can you see my screen? Thank you. Hello, everybody. I'm very, very pleased to be here. I have to ask for your forgiveness beforehand because I'm in London. It's around 7 a.m., not my best time of day. And I apologize especially to Mbak Silva and Mbak Mada because I speak very quickly. So forgive me if I speak a bit quickly, just go like this. I'll try to slow down. It's really interesting to follow on from Pak Andreasta because I think that we're talking about a different dimension of the same thing. I think you've heard a lot in the last couple of days about JKN and the scale up. But just to go to a bit of ancient history, if I may, I think, let me see. If we look at the promises, the political promises that have been made around health, they began obviously with the Constitution, with the first Constitution in 1945, and then with the Basic Health Law in 1960, which basically promised everything to everyone and then did nothing about it. And it wasn't really until the very last day of Megawati Sukarnoputri's regime in 2004, when the Social Security law was signed into law, that there was a framework to actually do something concrete. Then nothing very much happened for quite a long time. But this gentleman became governor of Jakarta. He inherited a local universal health insurance policy that was actually the work of his predecessor, and he engaged with that very actively. And so when he became president, he invested a lot in making this political promise come true for the nation. Now, the promise, so what we see was that actual, the coverage of JKN, which when we wrote this paper in 2016 was a big question mark, has actually been very, very effective. If what you mean by coverage is handing out BPJS cards. And I think that the promise was really very, very generous. So there were very low premiums, incredibly generous coverage at all premium levels, covering almost all conditions, including all diagnostic tests, procedures, and medicines, no co-payments, very unlike almost any other country, and universal and thus nationwide. Now, we've just heard from Pak Andreasta, better than I can say it, how illusionary that universal and nationwide is. So this was access to inpatient services in 2014. And as we've heard from Pak Andreasta, that has basically not changed very much. The result of this low premiums, very generous coverage has been a structural deficit from the start. So how do we deal with the deficit? Well, we have various ways of trying to contain costs. You've got overt ways, which is to increase premiums or restrict coverage. And you've also got covert ways, which are disincentivizing the use of JKN, and including by not solving the supply constraints. So maybe, Pak Andreas, that's something we can discuss later. Maybe it's deliberate because we can't afford to have more medical specialists because then we'll increase the deficit. We can talk about that later. But in terms of what's politically possible overtly, increasing premiums we know has been unpopular, although they have taken that step. Restricting coverage is something that people really don't want to hear about. We can pay less for our services, so we brought in the INA CBGs to try and bring down the payments for services. And the other thing you can focus on is paying less for your medicines and consumables. And everyone, except for the pharma companies that make it, tend to think that that's a good idea. So there's been a lot of focus on let's bring down the deficit by bringing down the cost of medicines particularly. And that's what I'm going to focus on for the rest of the talk, because that potentially has effects on the quality of products. And I think that it's important to say that this rhetoric about, oh, medicine prices are so high in Indonesia, it was true circa 2004. And so here you can see the ratio of Indonesian prices to the international reference price in 2004. This is on a log scale. And if you look at amlodipine 5, for example, which is the single most prescribed medicine in Indonesia, it was 46 times more expensive in the public system than the international reference price in 2004. And every single medicine that was measured in an earlier study by WHO was greater than the international reference price. Now, in 2005, Indonesia enacted some policies to prioritize what we call INN generics, so non-branded generics, which are branded only with their molecule name. And that was very effective, actually, in bringing down prices. So by 2010, way before JKN, a number of prices were much, much closer to the international reference price. In 2014, at the start of BPJS, Indonesia shifted, JKN shifted to the e-catalog system. So it was a public procurement system which has a single winner per area of Indonesia per medicine. So you're giving companies access to a market of hundreds, now 230 million people, and you're giving them universal access to the public system through that auction system. So, of course, a lot of companies bid very enthusiastically. The Ministry of Health set ceiling prices quite low, and over time, lower and lower. And the effect was that those already not that high prices came down a lot further in the public system. So on average, they fell by 63%. One of the things that really interests me is that actually the ones that were by far more expensive to start with were not the international imported medicines, but actually the Indonesian branded generics. So the big Indonesian companies selling branded products, those were the ones that were extraordinarily expensive compared to the rest of the market. And all of the prices have come down quite a bit. So now we had this rhetoric that was prices are too high. And now we've got this other rhetoric, which is, oh my goodness, prices are too low. That might be affecting quality. But wait, even last year, and the year before, very recently, we're still hearing these rhetorics about prices are too high. Let's cut the deficit because we've got to bring prices down. So which is true? Are they too high or are they too low? So I want to look a bit at the actual structure and the political economy of the medicine market in general. And what we've got is you've got a political promise of a healthy population. You want to deliver the maximum amount of health for the available amount of budget. So you've got to contain your costs. And one of the things you're going to do is cost containing procurement, which Indonesia has done very successfully. And that lowers medicine prices. in the public sector. But the providers, the supply side, and this is very similar to Pak Andreasta's presentation just now, the supply side is largely private, right? And so the private sector is trying to make money, but you've also got policies on the private on the supply side, which are largely protectionist, just the same as we've heard with medical specialists. Yeah, you can have foreigners, but only where we want them, right? So we've got protectionist policies. For example, we're trying to increase the TKDM, the amount of domestically produced product. And that some tax laws, some import laws are pushing up production costs for the private sector. So what happens, of course, is that profits get squeezed. Prices are coming down, production costs are going up, profits get squeezed. Now, companies react to this in different ways. So if we look at JKN, the principal mechanism for lowering prices of medicines is the e-catalog system, the public procurement system. And companies have basically three choices. Either companies exist to make a profit. So they want to keep their profit. They can either participate in the auction, and the result is going to be low price medicines. They can say, you know what, we can't produce at that price at quality, so we're going to get out of the market, and that causes a risk of shortages. Or they can say, well, we'll stay in the market, but we're not going to deal with the JKN market. We just can't be dealing with it. There's not enough money in it, and we're going to target the private sector, which interestingly in the Indonesian market is called regular. The regular market is the non-JKN market. So now the other people who are in this business to make money, as Pak Andreas has just pointed out, are the healthcare providers, with the exception of the public sector. But in the private sector, healthcare providers are also trying to make a profit. And don't forget that many of the doctors, as we've just heard, in the public sector also run private practices. So they're also trying to supplement their incomes by running private practices. So they also have a choice. So the principal cost containment mechanism for them is capitation funds and INA CBGs, which is reimbursement per diagnostic code. You get a diagnosis and you get a amount of money for that diagnosis, and that's supposed to cover everything: services, diagnostics, and medicines. So for that amount of money, what do you provide? Well, you have a choice of either providing e-catalog medicines or using your other funds, capitation funds, or your INA CBG funding to provide free medicines if you can't get them on e-catalog. Or you can say either there's a shortage, or I don't want to give you that for free. And then you upsell your customers. You basically say, listen, you could have the free vaccine, for example, but if you pay me 700,000, you can get an imported vaccine and your kid won't have fever for 2 days. You choose. And patients are very often either, guilt-tripped or pressurized by doctors who know about what's good and know about quality, but also patients' own perceptions will push them to have to demand a non-JKN medicine. Or there's a shortage, they simply don't have a choice, and they go to the private market. Now, those that can afford it can go to a pharmacy and get a good product. Some will say, you know what, maybe I'll go to Pasar Pramuka, which those of you who are in Jakarta will know is a big, slightly dodgy medicine market in Jakarta, or onto the internet. And there, of course, you can be subject to substandard medicine. So if you're looking at the effect on quality, the extreme price pressures may lead to cost cutting, may lead to substandard medicines. And the other mechanisms, the market dynamics, can lead to shortages and demand, including irrational demand for higher priced medicines. And that pushes people out of the regulated supply chain, and that makes them susceptible to falsified medicines. So these are the mechanisms that happen in the Indonesian market at the moment and that threaten quality. So I go back to our question: do we have prices that are too high, or do we have prices that are too low? overall, if you look at what's happening right now in the Indonesian market, these are the public procurement prices, the e-catalog prices, compared with the lowest price for any product in the Thai market. And overall, as you can see from this big red stack here, a huge number of medicines in the Indonesian market for which we had comparisons are less than a third of the Thai price. And Thailand is known to be a very good procurer. So you're like, okay, and some of them are less than 3% of the Thai price. You're like, how can you make lansoprazole, for example, at such a tiny price and to quality? Are they cutting costs? Might they be substandard? At the other end, you've also got the, wow, some things are really expensive compared to in international prices still. And if they're expensive in the public system, they're going to be even more expensive in the private system. Maybe that produces a falsification risk. So, how does it actually play out in the market? If we look just at one product, amlodipine, as I said, most prescribed product in Indonesia. Well, we did some work in principally in Kabupaten Malang in East Java, but also collected some samples in NTT in Soe. And Timur Tenggara Selatan. And we looked at the different prices for the identical product. So these are the prices that we found in the market, real prices paid for by us trying to buy medicines, by the team in the field trying to buy medicines. And the price for the same, for 5 milligrams of amlodipine, but different brands, ranged between 60 rupiahs to over 7,700 rupiahs. So that's 128 times as expensive for the highest price compared to the lowest price. So that's a pretty big gap. But what's happening here? Sometimes it's the same company. These are different brands, but sometimes it's the same company that is making a very expensive brand that's also making a very cheap brand. So if we compare, this is looking at the HET. The HET is the maximum retail price, the harga eceran tertinggi, and it's the price that's set as the maximum price that the company is allowed to charge for that medicine. Now, the price is set by industry, but approved by the government. And it sort of reflects what the company thinks is the value, what they're trying where they're trying to establish their brand value. And you can see that there are very large differences here too. So some companies are making both really quite cheap products and very expensive products. So if we look at company number one down here, there's a 20-fold gap between the ceiling price, between its INN generic, its unbranded generic, and its branded generic. Right? These are just of samples that we picked up in the field. Now, if we compare that to the price that is actually paid for the medicines, which is the blue here, you can see that actually the price that's actually paid, that our mystery shoppers paid when they went to buy the medicines, varies, but also bears very little relationship to the maximum retail price. And where you see the blue to the right of the red here, what you see is that the price that's being asked by pharmacists and doctors is higher than the maximum retail price. And you can see that quite a lot of them, it's quite a lot higher. So the maximum retail price is kind of notional. On the other hand, we sometimes see that it's lower. But also, so we've also got a 17-fold difference in the actual price of different brands provided by the same company. Now, the other people who are profit maximizing are apothekers themselves. So the profit maximization in the HET reflects what companies expect. The difference in the blue, that's the difference in the red dots. The difference in the blue is actually the market. So some of that excess price is being picked up by other actors in the market, the distributors and the dispensers, usually pharmacies. If we look at what pharmacists do, these prices compare the identical product. So this is the same brand of the same medicine at the same dosage. And we're seeing differences of 6-fold in what people are charged. And it can be by different pharmacies, because this one has ASE and it's a chain pharmacy, and everyone's in white coats and they're very gangsy, compared with something that's a ruko on the side of the road without air conditioning and etc. That might be it. Or pharmacists in the same pharmacy look at different clients, and this one arrives in a nice Mewa, SUV, and we're like, oh, we can charge them a bit more, and they'll vary the price accordingly. So there's profit maximization going on all over the place. In summary, basically, the Indonesian medicine pricing rules de facto are very different than the rules de jure, and they are basically what the market will bear. Patients will bear high prices mostly because of a perception of quality. If it's more expensive, it must be a better product, but they're pushed towards that by healthcare providers who are also making money out of selling higher priced medicines and saving money by not having to pay for medicines out of the INA CBG money that's paid for by JKN. Some of the public sector prices appear to be way below the cost of what would be quality assured production plus tax plus fair profit. So that's a real worry, because when you look at some of those very, very low prices, you think this must be garbage, because you cannot be producing this product at this price at quality. On the other hand, it is possible that companies are bearing these very low prices because, so you ask yourself, well, why do you bid so low for these JKN products? Well, one, it gives you access to a massive market and to the national distribution networks. So if you're a newish company and you want to make a splash in the Indonesian market and you want your brand to be known and your distributors to get in all over the place, one of the things that you can do is to become an e-catalog supplier. Also, companies are amortizing their loss on a particular product. So the JKN products can be like loss leaders in traditional supermarket marketing. You can amortize your cost over a whole portfolio, including higher prices. Now, I know I'm at time, but I want to share with you something that no one else has seen. It's brand new, hot off the press, and it's an answer to this question. So in the best possible case, what we're saying is, because some medicines are really quite expensive in the Indonesian market, mostly in the private sector, it means that we can have very, very low price medicines in the public sector that are still at quality because of what you could call cross-subsidization. Now, how would you know this? You would have to sample those medicines and take them to the lab and test the quality and compare that with their price. And hot off the press, we've done that for you. No one has seen these data. They only came back from the lab a week ago. So from lab to public disclosure, I think this is almost a record time for research. And what we find is, amazingly, every single medicine meets specifications, both for assay, the amount of active ingredient in it, and dissolution, formulation, the speed at which it dissolves in the lab, but mirroring what happens in your body. So if you look at this, the upper limit, the two red dotted lines, and I'm sure it'll be very small on some of your screens, but the two red dotted lines here are the limits of pharmaceutical quality, basically. So ideally, you want to be at the 100% range, along the 100% line, but all of these are acceptable quality. And every single one of the 204 samples that we picked up of cardiovascular diseases, 5 molecules in Malang, met quality. And you can see that there is zero relationship between the price and the quality. So the very, very low priced ones over here are just as good as the quality ones here. Now, are these companies cross-subsidizing? Well, in the sample that we picked up, we did find some that were cross-subsidizing, and I've color-coded them for you here. And so these are the ones that are the same color are products made by the same companies at different price points. And you can see that they vary almost not at all inequality, they're all within range. So what's the final message from this? Well, number one, you could say, oh my goodness, well, we need to push everyone, to only buy cheap generics. But actually, it's because there are these expensive products, potentially, it's because there are expensive products that companies are able to make very cheap medicines at quality for the public system. So my policy take-homes from this, and I think my co-authors would share this, are that those who choose to buy expensive medicines out of pocket should have that option. And I think this goes back to something that Prof. Laksono said on the first day of this conference, which was, he said, the private sector is going to have to pick up more and more of the financing. Well, one of the ways you do that is by out of pocket, but we wanted it to come out of the right pockets, the pockets of the people who can afford it. And that means that the public sector must be providing for those who can't afford it. And that means that they have to incentivize secure and equitable supply so that they don't have shortages, so that those who can't afford it get pushed towards more expensive medicines. And you do that two ways, by incentivizing your procurement system correctly, and by making sure that reimbursement policies don't push doctors and healthcare providers to push people outside of the regulated system. We've also seen that price caps like the HET are basically useless. Now, I want to acknowledge my co-authors who will be on the panel here, so you can ask questions to them as well. The Malang data and the lab data that study was managed and run by Aksari Dewi, who's on the panel, and Amalia and Rembus were also involved in the supply chain work. So please address your questions to them as well. And I'm very sorry for being over time. I take it as my privilege for having to get up at 6 o'clock in the morning. Thank you.
Thank you. I was about to say that as well, Ibu. You have more time because you woke up really early in the morning in London. Thank you. Now I'm opening the question and answer session. We will have maybe 2 to 3 rounds with 2 to 3 questions for each round. And I can see I have 3 questions already here. So I will read the first question. It's from Andre Suryanta. The question is for Pak Andreasta. To my understanding, the new investment list, President Regulation number 10, 2020, no longer has foreign ownership or location restriction for hospitals. But then the government issued a regulation limiting foreign hospitals to 200 beds maximum. Is there appetite for foreign investors for setting up mid-large size hospitals in Indonesia? That's the first question for Pak Andreasta. The second one, also to Pak Andreasta, it's from Dina Fauzia. Thank you for your very clear presentation, Pak. As you mentioned, there is a bottleneck problem in medical specialist production. Do you think changing the education system for a medical specialist from university-based to hospital-based might be a good solution? Okay, that's 2 questions for Pak Andreasta, and I have one more from Ross McClough, but he'll do it live. Please, Ross.
Thank you very much. I take it you can hear me. My question is really quite similar to the 1 or 2 that you've just read out, and that is that looking at the data that Andreasta presented on the distribution, or the very uneven distribution of medical specialists and hospitals across the archipelago, it's quite amazing that the government would have a policy that prevents foreign investment in hospitals in the rural areas. I mean, if the government really cares about the rakyat are out there and they haven't got hospitals and or doctors to look after them. So it seems pretty obvious to me that the government needs to realize that its policies are protecting the medical profession, and the objective should be to protect the people, not the doctors. So that's a comment that Andreas might like to comment on, or Elizabeth for that matter. Thank you.
Baik, so Pak Adresta, maybe you can go first, then Ibu Elizabeth at the end, maybe you can add more, especially for the third questions from Ross McLeod.
Thank you very much for the questions. And this is related to the new regulation that foreign investment in the hospital sectors, the daftar negatif list is already enacted, so they can work in the rural. But then we can see that the comfort zone is already there, does exist. So it's not easy for them to move to the rural area. And also this is related to the strategy to go to Indonesian market. As Ibu Pisani mentioned, if we look at the from the total health expenditures, the out-of-pocket is still 37%, and this is mainly from the major island or the major cities in Indonesia. Based on their the first interest to do the business is not really interesting to open the hospital in the rural area unless the government incentivize this and then provided a lot of privilege for them to work in the rural. So traditionally we have private sectors, so-called private sectors in the rural area, but this is a mission-based, this is faith-based organization that be there. But for-profit organization will not be in the rural area. And also in Indonesian hospital itself, we have seen the shifting from non-profit to for-profit entity. So I mean that the health expenditures, this is the main reason where they can get those BPJS pocket and also out of pocket from the people. And then the second question about the medical specialist production, whether this is good if we shift from university to hospital. So so far, the mechanism of the education itself is not really clear. Just recently, for example, in our university in UGM, the medical specialist education is shifted to the university. Before, it is under the university, but never registered in the university. So you can see this is a really tangled situation because the college and also the hospitals and also the university, they run this all together. But again, the administrative side is not really clear. So just last year, the education is moved from the hospital to the university. And is it, how do you call it? Is it good for to increase the production? This is still a big question mark, because only around 24 out of 91 of medical school can produce or can educate medical specialists. So we are not really clear whether we are now in hospital-based or university-based. So the system should be, how do you call it? Should be discussed first, and then we have to come up to a certain agreement to which system we should apply to produce medical specialists. And also about the protection of medical doctors is really obvious in Indonesia because one example, if the Indonesians, they get the education from abroad and they will work in Indonesia, so they have some special program, such kind of acclimatization. They have to be adjusted first, accordingly to the system in Indonesia. and this is not favorable for the Indonesian medical specialists who get their degree from abroad. Thank you, Elena.
Thank you, Pak Andreas. Ibu Elizabeth, do you want to add something?
No, I think that Ross answered his own question. Are they protecting the the medical profession, not the rakyat? Well, yeah, in the same way that the Australian government protects the mining companies, not the environment. Yeah, that's politics, tragically.
Yeah. All right. I'll read maybe 2 more questions due to the time limit that we have now. So we have one question for Ibu Elizabeth from Lila Sari. Thank you so much, Elizabeth, for your very excellent presentation. I enjoyed so much. I would like, why it's gone? All right. I would like to ask whether you have some evidences on the health providers pushing the clients to get more expensive medicines. I know it is common practice, but it is difficult to get the data. If you get the data, how did you do it? If not, other methods you could do. Thanks so much. And I have one other for Ibu Elizabeth as well. Interesting presentation by Elizabeth Pisani. I was curious about the bottlenecks in the implementation of national health insurance. You had mentioned supply side constraints. Are there other bottlenecks? Thank you. There are two questions, and this one is from Vivek Nelakantam. Please, Ibu.
Thanks. For the first question, I think that some of my co-authors will be better placed to answer it. So we did, besides doing the quantitative study, we also did qualitative work. So we did interviews with healthcare providers, ranging from village midwives through hospital directors, pharmacists, directors of the district warehouses. I think maybe Sari or Embus, you'd like to give an example from some of your interviews of what people said about pushing clients towards more expensive medicines, or in fact, Amalia, from your earlier study. I think all of you have data that from qualitative research that confirms that. Would one of you like to contribute?
So I can go first. So in my interview, I found out that pharmacies looking for patients by like targeting them as their the lookings, like to Elizabeth say, if they're coming with some expensive bike, or they just come by using like they're indicated as a poor patient, they will adjust the medicines related to the price that they mention. Like if they are poor people, for the INN with 5,000 or 5,000 rupiahs. And when they come with the good car, they will try to sell their premium products to be able to make a good sale, because they are profit driven behave for that, to increase the revenue. So they are targeted by the owner of the pharmacies too. So that's why we believe that this has become the data that what the people who ask this question mentioned.
Thanks, Embus. And Amalia and Sari both found exactly the same thing, talking to different people, including healthcare providers. We also note that in our mystery shopper data, the highest prices were from Bidan Desa and doctors. So they were charging more than pharmacies, which is also a bit of quant evidence. On your second question, what are the bottlenecks in JKN? Well, there are very many. The supply side is one of the biggest ones, but there's also a lot of administrative bottlenecks. And I think, Sari, you've actually got a very good example of that from Malang in the adjustment. So BPJS, to their credit, they try and adjust to changing circumstances, including, for example, in the pandemic. But sometimes the red tape just gets in the way. So the processes can be a bottleneck. Sari, maybe you can share the example related to their trying to change the iteration so that people could get their medicines in more easily in the pandemic.
Yeah, from one of our interview with the people from the RSUD, the public hospital here in Malang district, we found out that BPJS Kesehatan in the beginning of the pandemic, they issued a iteration policy which allowed the patient to take home the medicines for 2 months consumption. Usually before COVID, they just get for 1 month consumption.
But the problem with that policy was that in the end, the hospital complained about it because.
Yes, because for the second month, the hospital can only claim for the medicines only. They don't have the claim in the INA CBG's package for the service.
So that's one of the things that I was referring to when I said that reimbursement policies need to be adequate to avoid perverse incentives. So in this case, it's the process factors in BPJS, which sometimes can actually actively disincentivize the provision of services. So I think that there are a lot of bottlenecks related to the processes and red tape. And to be fair, they are being worked out over time. So we get many fewer complaints in interviews now than 2 or 3 years ago. Thanks.
All right, maybe I'll read one more. Then both Ibu Elizabeth and Pak Andreasta can just answer it as your closing remark as well, because we still have less than 1 minute. Could the panel comment on the fees charged by medical schools in both the public and the private sector? It seems that there are very few scholarships so the great majority of students come from well-off families. They have little motivation to work in the remote or rural areas. Is there a solution to this problem?
Thank you very much for these difficult questions. So in our paper that we wrote down with our colleagues from Australia, from Thailand, and other Sharo regions, we can see that the scholarship for the students from rural area can be one solution. But once they become a medical specialists, they don't want to go back to their hometown because of the unavailability of the hospital or well-equipped hospitals. So this is also related to the question that whether the private sector can open their business in the rural area. If they go to the rural area, they cannot bring their own doctors, so they will get the doctors from the public sectors. So the dual practices will be increasing again. So if we try to educate the medical specialists, we have to be aware also about the professional support for them in the rural. It means that we have to provide a good hospital, well-equipped hospital for them to work with it. Thank you, Helena.
All right, Ibu Elizabeth, 30 seconds.
I have nothing to add. I think that Pak Andreas has covered it.
All right. Terima kasih banyak. Thank you very much for all the panelists and the co-authors that are joining us today. I'm afraid we have run out of time. I do see some questions that haven't been answered. Pak Espinal, I'm very sorry I didn't see your hand when you're raising your hand, but maybe after this, Pak Andreasta or Ibu Elizabeth, you are welcome to type your answer if you can see the questions from them. And I'm going to hand over the next session to one of the Indonesia Updates conveners, Dr. Firman Witular Karta Adiputra, who will chair the closing remark. Thank you so much.
Thank you. Thank you, Helena, and thank you, the speakers from the last panel. So good afternoon again. I'm Firman Witular from Indonesia Project, and I'll be chairing the final panel of this conference. We are very happy to have Dr. Ines Atmo Sukarto from Lipotech Proprietary Limited and ANU, who will now deliver the closing reflections of this conference. Dr. Ines is a biomedical scientist with involvement in vaccine development with both academia and industry affiliation. She has worked as a research scientist at LIPI for a decade after finishing her PhD in Adelaide before moving to Canberra to work in vaccine development. She has built a strong ties with Indonesian vaccine manufacturer, Bio Farma, BPOM, and research institute in Indonesia such as the Eijkman. Now, in the past 18 months, Dr. Ines has been actively involved in discussion with civic societies, academics, as well as stakeholders in various ministries, where she has tried to give her independent point of view. And she also lent support to Indonesian Young Scientist Forum and Aliansi Ilmuwan Indonesia untuk Penyelesaian Pandemi. Mbak Ines, the screen is yours.
Thank you very much for the very kind introduction, Mas Firman. I will just use some slides just to guide my remarks. Obviously, this is not a lecture, but I would start by, can you see my slides? Yep. Yep. Okay. I want to start before my closing remarks to just thank the organizers for the opportunity to give the closing remarks this year. I've always enjoyed attending the Indonesia Update conference, as this meeting is kind of unlike any of the conferences that I attend as a biomedical research scientist. It's definitely different to the usual presentations that I have about, like, you know, the intricate workings of the immune system or presentations on tumor growth. So I really thoroughly enjoy them. But for sure, the last 20 months have taught me something, and it's taught me that I have to look beyond the things that I'm comfortable with. And this period and this crisis has also shown me the importance of cross-disciplinary dialogue and collaboration. For example, as someone who spent more than a decade now working on vaccine development here in Canberra, this year has highlighted the importance of science communication and health equity in ensuring that the vaccines that people like me and researchers all over the world develop end up actually having the impact that they're designed to have. Because unless those vaccines are in our arms, those vaccines won't have an effect. So my closing remarks are very much a personal reflection on the pandemic and what it has highlighted and how Indonesia can use the opportunity to improve clear issues with a system that's actually allowed 4 million people to die, to be infected, and 140,000 to die. So if I can go to the next slide. So while preparing, I realized that had this meeting been conducted in July, the collective tone, I think, at the conference would have been definitely more somber, because as highlighted in these graphs, by mid-July, we saw the Delta wave rip through Java and Bali with such aggressive force that it left us all, especially us in Australia, feeling really helpless. And there's probably no one in this Zoom that's not been personally affected by the Delta wave. We all know, I think, someone who's either been infected, who's been severely ill, or who has died because of this virus. But like in India, the wave that rapidly ripped through Indonesia's mostly the most populated islands. And then we watched, with horror, how hospitals were running out of beds and ICU facilities, oxygen and drug. But then by mid-August, just in time for 17 Agustus, numbers were going down. And today, cases are hovering just around the 4,000, and testing positivity rate has also plummeted. So now even Indonesia's neighbors, Malaysia, is kind of jealous of this trend and kind of can't understand what Indonesia has done. I suspect that, like India, Indonesia is probably seeing the effect of natural immunity in these highly dense cities, especially in Jakarta, which were originally driving the pandemic in June and August. And in fact, even before the Delta wave, a study by Universitas Indonesia suggested, based on the surveillance, that half of Jakarta's population had likely been exposed to the virus. So the pandemic in Indonesia is kind of started like, true Javanese style, I'd like to think. Alon-alon asal kelakon, right? You can see on the graph how it took like from March to January this year to reach that 1 million case. But then 2021, this year, has been so different because in 9 months, Indonesia actually accumulated 3 million official cases. And that's despite starting vaccination kind of around here in mid-January. By June, though, with following Eid al-Fitr, and as Dr. Charlotte reminded us, because of the reluctance to tightly control people's movement, cases ramped up rapidly, and Indonesia overtook India as the COVID epicenter of the world. What we often forget is the fact that, and I'm trying to show this here, that by, at that time, the UK which has relatively high vaccination coverage, so similar increase in cases. It's kind of like amazing how it superimposes in June to August. But while Indonesia's cases have declined, so Indonesia here is in red, like the UK is still hovering up there. So I think that this is a reminder to the government, as the Indonesian government is probably trying to figure out how to reopen its economy. It's a warning, which is important because the UK, which has a vaccination rate of 65%, double vaccination. Indonesia has only fully vaccinated about 15% of its population, I think. So admittedly, natural infection will add to that 15%, but Indonesia needs to make a decision. And, to make this decision, it really should have its own data and understand the prevalence of antibodies in its population, before drastically opening the economy. Having said that, the protection that the vaccines are offering in the UK is clear, because despite the fact that the UK has about 27,000 cases, it recorded about 150 deaths. While Indonesia, with its 3,500 cases, recorded about 237 deaths yesterday. So my reflection would not be complete without a reference to Indonesia's former health minister, Terawan Agus Putranto, military doctor with close ties to Jokowi, and with at best a dubious technical track record that includes the use of unapproved therapeutic treatments. Now, Terawan, I believe, set the country on a dangerous course last year, as he failed to perhaps grasp the gravity of the situation, or if he did, then he failed to communicate it. Now, who can forget some of his classical quotes that Indonesians are immune to the virus, keturunan Gajah Mada, that Indonesia's climate is not friendly to the virus, or that we shouldn't worry because most people get better, nanti juga sembuh. He even entered into a debate with scientists from Harvard, who at the beginning of last year were raising concerns that Indonesia wasn't detecting or reporting any cases, when in fact Indonesia for a long time only had a handful of labs that were able to do the tests. Of course, if you don't test, you don't find. So under this, under his watch, Indonesia's Satgas was promoting a strategy unlike any other, and I had to put it in this talk because according to them, 80% of the fight against the virus is psychological, right? And for that, we need to be happy, not panic, and exercise. So clearly, these ministers' decisions were not science-driven. And that's really when, seeing this sort of information, this is when like scientists like me really decided to try and get out there and put out better scientific information. So the truth, I think, is that Indonesia's fight against the virus was handicapped by the complicated leadership, in the fight against the virus. And although Jokowi was repeatedly affirmed to be the highest commander, I think in truth he rarely appeared as so. He's got two lieutenants, Pak Luhut and Pak Erlangga, who've been put in charge, but in both cases, it's been clear that the priority has been preserving the economy. And then you've got a second in line, Pak Budi Gunadi Sadikin, Pak Erick Thohir, and Ibu Retno, and all three of them have had critical roles, but more technical roles. Ibu Retno, for example, tirelessly negotiating access to vaccines through various approaches, COVAX, as well as creative approaches to allies. Erick Thohir, with his BUMN, played a critical role in the logistics of vaccine distribution, including the Sinovac vaccine, which is actually purchased in bulk from the Chinese company and then bottled up in Indonesia. Pak Budi, as a banker, I'm sure that he's I think he had the hardest job, really, to be honest. But as a banker, he's got to be a numbers person, and he is. And his input in improving the data, has been noticed. Although I think, as my colleague Pak Iqbal highlighted, I think there is a lot still that needs to be improved. It's only after Pak Budi took over from Pak Terawan in December that we've seen improvements in, like, for example, dashboards on the Kemenkes websites. Nevertheless, I think that the quality of data remains an issue. Pak Budi promised 1 million vaccinations a day, though. I think this has proven to be a challenge. However, I think I'd like to remind everyone that Indonesia, despite the fact that it's only 20%, about 22% single dose and 15% double dose, that's still 118 million doses of vaccines that have been delivered in Indonesia. That's a significant achievement, especially in light of our own vaccination here in Australia. I think that's kind of like vaccinating Australia twice or almost 3 times around. Bu Penny from BPOM definitely has played a critical role, because BPOM has had to review all the different vaccines and treatments as well, and some of them have been quite controversial during the pandemic. And then we've got the Jubir Satgas as well. So, there are so many people involved that it's kind of difficult to know who's in charge. Now, as Dr. Charlotte reminded us in her political update, the pandemic has exposed how broken politics can sometimes be in Indonesia. And the fact is that the country's response to the pandemic cannot be decoupled from politics. Similarly, on the second day or first day, Pak Asep and his colleagues explained to us how the economical challenges that this pandemic has brought, the wave of infection, and then all the restrictions, all the economic restrictions on activities, which have been necessary to tackle the pandemic, that's put a huge pressure on the economy. So, For me, as a scientist, the pandemic has shown how inadequate Indonesia's health system was in gathering and using its own data. And as Pak Iqbal showed, this void has been filled by volunteer organizations, which have tirelessly highlighted the discrepancy in data reporting. Clearly, one of the greatest challenges in this decentralized system has been real-time reporting of the accurate information, and this puts Indonesia at a disadvantage. In a pandemic situation, the response needs to be driven, needs to be dynamic, and it needs to be based on accurate information. How else can resources be equitably distributed otherwise, right? So I am a vaccine researcher, so I couldn't have a reflection without touching on the subject of vaccines. Now, it's interesting because Indonesia has one of the most complicated vaccine landscape when it comes to COVID. It's administering, at least 6 different vaccines now, and that's covering 3 different platforms, technology platforms. 2 of them are novel, and in fact, in this infographic, that doesn't even include the J&J vaccine. Now, the Novavax vaccine here, I think we've got agreements. Indonesia has agreements in place, but Novavax has not managed to deliver yet on those. And then we also have the ambition of developing Indonesia's own products on the vaccine Merah Putih, and also vaccine BUMN, which is kind of a little bit less known, but vaccine BUMN is being developed at Bio-Farm at the moment using a seed and technology from Baylor's College, and I believe that it is probably in a relatively more advanced stage than vaccine Merah Putih. So it will be to see whether which one ends up being on the market first. To close my remarks on the vaccine now, even this has been shrouded with controversy, right? First, we had the vaccine Mandiri, which then was rebranded as vaccine Gotong Royong, right? So that was a problem. That was a program that allowed companies to purchase vaccines and of specific brands, specifically for use by their employees. Now, this approach, I think I myself saw, and many others saw as unequitable, as an unequitable approach to vaccination. But then in the end, it proved to be a flop, because it turns out many companies will not pay to protect their employees when those employees can get vaccinated for free. And then more recently, we had the polemic of the vaccine boosters, right? The boosters are supposed to be given only to the healthcare workers. And that was because during the Delta wave, we saw this huge loss of life in the healthcare profession. And Moderna vaccine doses were approved to be used as a booster for healthcare workers only. Unfortunately, I think many have seen on social media that people with connections seem to have received their 3rd shot. So again, this highlights a significant problem, considering that 80% of Indonesia's population is yet to get their 1st dose. Now, as a scientist, can't resist but reflect on how the gap between the scientific and political sphere is widening in Indonesia, and something that I and others strongly feel needs to be rectified. Examples of this, include how the government was initially using rapid antibody tests for screening in the early days of last year, right? And this is probably when I thought that I should get out of the lab and start talking about the fact that those tests were not relevant to fighting the pandemic. And whilst I have to acknowledge that numerous ministers have sought input from scientists, including myself, it's concerning to read statements such as the one from Pak Luhut, which was, I think just in July, when he said, now we understand that tracing is important in handling the COVID-19 pandemic. In July 2021, 18 months after, into the pandemic, although I don't have time to elaborate on all the other examples, then I've got to highlight two of my favorite, and that's Vaksin Nusantara, who again is at best to say dubious vaccine developed by Terawan and Genos. Now Genos is interesting because this was touted last year as an example of ingenious national innovation.
Sorry to interrupt, you have 2 minutes.
Yes, but many, including me, raised the fact that this the technology had not been sufficiently been evaluated. So the issues that I've described demonstrate that the pandemic has highlighted many of Indonesia's weaknesses, and the purpose of this reflection is not just to point to those, but to say that I think if there is political will, this tragedy of the pandemic should and could be turned around and used as an impetus to deal with those issues. And this slide shows many of the issues that have been raised by all of the speakers today. And I think in the end, what I'd like to say is that in the end, as we move from this suppression phase that we're in towards a stabilization phase, then as many, including my colleagues at Aliansi Ilmuwan Indonesia untuk Penyelesaian Pandemi have said, we need to understand what the scenario is for coming out of the pandemic, and importantly, Indonesia needs to actually try and learn from these mistakes and turn these mistakes, the mistakes or the learnings from this years, turn them around. And just before closing, I think something that has also been discussed or put forward is possibly the need for a CDC-like institution, because I think what's clear is that the Dirjen P2P, Dirjen Pencegahan Penyakit Menular, has failed to prevent and respond to the pandemic. And Mas Firman, my last slide is I really hope for return to the reopening of the borders, to travel, in-person meetings, in-person collaboration, and just the simple joy of sharing a meal with others. I mean, I think this is really, at the end, what we all are missing. Thank you very much.
Thank you so very much, Mbak Ines. For your hopes. Well, thank you so much, Mbak Ines, for a very clear, thoughtful, and sobering closing reflection. And that wraps up the panel for the conference. Although if anyone's are interested, we're going to open a Zoom room for anyone who still want to hang out after the conference. Now, on behalf of my convener, Ariana Utomo, and myself, as well as the ANU Indonesia project, I would like now to go through a list of people and institutions that we would like to thank and acknowledge for this event. First, I would like to thank the Department of Foreign Affairs and Trade, DFAT, for their continuing support for the Indonesia project and ANU more broadly. I'd like to thank the Australian National University, in particular the College of Asia and the Pacific and Crawford School of Public Policy, and other institutions that provide ongoing supports for Indonesia project activities, including for the update, including Australia Indonesia Youth Association, PPIA, and PPI Dunia. I would now like to thank those involved in organizing the event, Blaine, head of the Indonesia project, and the team, the great team that who have done an incredible job in handling the planning, the administrative and logistics preparation. Kate McClinton, Kate, are you here? Yes. Chut Nurkamala Mulyani, Nuke, or Ichut, Lydia Napitupulu, and Gemas Sadiadi. I would also like to thank those who provide additional support on the days. Charlie Barnes, are you here, Charlie? Andi Laksono and Ginanjar Panggali. Now, I would also like to thank all my colleagues, my Indonesia project colleagues, and any colleague who provide feedback throughout the planning of this conference. I would now like to thank the speakers, the discussant and chairs who's done an incredible job and presenting their important work and in the past 3 days. Some of them are still here in the panel. And I would like to thank Silva Isma and Ramadhani Rahmi from Juru Bicara Indonesia that provided sign language translation to Bahasa Indonesia. And I don't want to miss this, but I'd like to have thank personally Ross McLeod to come up with the title of this update in sickness and health. And finally, I'd like to personally thank my co-convener, Ariana Utomo, Ririn, who's been such a wonderful co-convener to work with. Thank you, Ririn. And so before I end this session, I'd like to mention that the proceeding of this year's conference will be published next year in collaboration with the ICS Yusof Ishaq Institute. Again, thank you everyone for participating. Hoping to see everyone again in the next update, hopefully in person. Thank you and goodbye. Again, those who still want to hang out, we can go to the other room. Have a nice weekend, everyone.